Right, good afternoon, everybody, and welcome. Well, oh gosh, yes, and now we can see ourselves. It's quite disconcerting, that, isn't it? Yeah.
You talk to yourself.
Yeah, well, there's nothing unusual there. So, welcome everybody to the Suffolk and North East Essex Integrated Care Board. I would say our first, if in inverted commas, proper meeting, perhaps. Our third actual meeting, but first of the, if you like, the standard ilk. So anyway, what I'm going to do is go round the table for intros so that people know who's here, and particularly our colleagues from members of the public also know who's here. And also I'll give you a chance to introduce yourselves, if that's okay. It would be really helpful. So let me kick off by saying that I'm Will Pope. I'm the independent chair of the Integrated Care Board, and I'm going to go this way first with you, Ed.
Hi everyone, Ed Garrett. I'm the Chief Executive of the ICB.
I'm Andrew Kelso. I'm the Medical Director for the ICB.
I'm Nick Rayner, GP, representing Suffolk on the ICB.
Good afternoon, all. Richard Watson, Deputy Chief Exec and Director of Strategy and Transformation.
Partnership. Good afternoon, Amanda Lyes, Director of People and Workforce for the ICB.
Good afternoon, Peter Fairley. I'm Director for Strategy and Integration at Essex County Council. I'm actually here as a substitute today for Patrick Higgs, who's typically our representative.
Hi, I'm Frida Barty. I'm a GP representing Essex, North East Essex.
Hello, Nick Hume, Chief Executive of Vesneft.
Hi, I'm Tanya Curry, non-exec member.
Hello, I'm Lisa Nobes. I'm the Chief Nurse for the ICB.
I'm Chris Armitt. I'm Acting Director of Finance for the ICB.
Thank you. I must remember to do the microphone. Now, would you like to introduce yourselves, colleague? You might have to shout for us there.
Michael Nimmy, I've been following your machinations for about the last 13 years.
I'm Robert Wright. I'm a radiology support officer at Clapton and Colchester Hospital.
Peter Cook, I'm Associate Director of Innovation and Education at Essex.
Gary Horn, Deputy Chief Executive at Colchester Institute.
Cerise Chandler, I'm a Regional Partnership Lead for NHS Business Service Authority.
Fanwam Chumburi, I'm the Chair of the Ipswich East Alliance Executive Delivery.
Victoria Fennell, Senior Workforce Programme Manager in the ICS Workforce Team.
And I'm Simon Morgan, Associate Director of Communications for the ICB.
Wonderful. Thank you very much all. So, lovely to see you all. First item, though, we'll get straight into the business. Notification of any questions from members of the public. Joe, do we have any notification of any questions? No, none raised. Okay, thank you very much. Apologies for absence. I have, and Joe, you'll correct me if I've got this wrong, I'm sure. I have Craig Black. Also, well, Peter's already mentioned Patrick, but you're deputising for Patrick. Peter, thank you. Sue Cook, but Stuart, you're deputising for Stuart. And then we have a late apology from Maddie as well. I believe Maddie's not feeling very well, so we send her our best wishes. Joe, did I miss anybody there?
No, I haven't had apologies from Stuart Richardson.
Okay, well, let's see if he shows. Okay. Then let's do declarations of interest. So are there any declarations of interest or potential conflict of interest with any agenda item? Stuart?
On the information function paper, Suffolk is bidding to be one of the
providers of that.
Okay, so we'll note that. Thank you, Peter.
Yeah, thank you. I think Essex County Council is also in a similar situation. Separately also, I don't think this is a conflict of interest, but just in the interest of transparency, I am also the local authority partner member on the Mid and South Essex ICB, so if anybody takes offence at that, wishes me to leave at any moment, I thought I would share that.
I can guarantee that no offence has been taken whatsoever. You're more than welcome. Okay. Any others, or is that it? Good. And let's go on to item 4 then, which is the minutes of the previous meeting, 26th of July. Now, it's 6 pages. I'm not proposing to turn the pages unless you want me to. Does anybody have any issues with respect to accuracy in the minutes, 26th of July? In which case, is the board happy to agree those draft minutes as a true and accurate record? Agreed? Unanimous, thank you very much. And then we're also asked to endorse the email meeting, which closed on the 1st of August, and the details of which have been circulated to you. And it was very specific on membership of audit, remuneration and HR committees. We've already approved it electronically, but we're asked today to endorse that approval. Is everybody happy so to do? Endorsed, that's great. In which case, then let's go on to item 5, which is matters arising from the 26th of July. There are only 4. So the first one, number 11, NEM capacity, is actually on the agenda today. So is everybody happy that we just deal with it in the normal course? Thank you. And then 22 has got 2 parts to it, the North East Essex Diabetes Learning and the Dentistry Access Update. Richard, can I come to you for that?
Yes, so on the first one, we've got a first draft briefing from the team in terms of looking at the diabetes provision across the 3 alliances that make up the ICS, and we're sorting a meeting internally to review that. There is also, through the ICS Diabetes Committee, plans for a workshop at the end of November that we're just currently planning to take stock of that and look at what the options are, but how we take that forward.
Okay. Any questions for Richard, or is everybody happy with that update? Great, thank you. And number 23, which is the pay settlement and relationships with primary care. Chris, can I come to you?
Yeah, the answer that we had on that one from NHS England was unfortunately no. There wasn't any further funding for general practice contracts or primary care in general as part of that.
Okay, so that's a simple matter of fact. It probably would be inappropriate for you to ask if people are happy with that, but that is the fact. Okay, thank you very much. And then the final matters arising was actually to be dealt with outside the meeting action, Nick, and it was for Craig to clarify with you those phlebotomy numbers. Do you feel clarified?
Unfortunately, I haven't had that fully clarified yet.
Shall we carry that forward?
Email, so it's still in track.
We'll carry that one forward then. Thank you very much indeed. Is everybody content with those matters arising as reported? Richard?
Apologies, I didn't cover dental, so
Oh,
is it
sorry,
worth me?
Richard.
No,
Yeah.
it's my fault entirely. So just to colleagues' benefit, we do have the dental task force in place that's meeting every 8 weeks, ably supported by one of our best, Greg Brown. That group has got a programme plan in place which is looking at what we could do now in advance of any change of commissioning arrangements from NHS England to the ICB. Just to give you a flavour of a couple of things that we've got underway, we volunteered to take part in an NHS England pilot for primary dental care. That's bringing in extra urgent activity into the area alongside regular appointments. We're currently working with NHS England on the exact detail of what that could look like, and obviously it's still inherent in terms of whether or not practices would actually buy into that. We've also prioritised children in care. There was a particular issue with access for children in care across the ICB. We've now pretty much sorted that, so waiting lists are pretty much nil now, which is a great improvement on where we were. And just finally, a very niche group but important, homeless. We're also exploring what we might be able to do locally for those amongst the community who are homeless, who have particular access issues, you can imagine, into dental. So let's just give you a flavour of some of the shorter term actions we've got underway, but we're not waiting until April, we've got things happening now.
Very good, very helpful, Richard. Thank you very much. So with that further update from Richard, is everybody content with the matters arising updates as reported? And then with respect to the matters arising log, is everybody content that the log accurately captured the matters arising from that meeting of the 26th of July? No additional matters arising, true and accurate, agreed. Thank you very much. In which case, let's move on to item 6, an update from Ed. Over to you, Ed.
Thank you very much, Chair. So 4 updates to make. That most of the issues are obviously captured on the agenda. First thing to say, it's obviously been a momentous time in our national life since we last met, and I think we would all recognise the leadership and the beyond extraordinary public service that the Queen gave us as a nation. So just wanted to recognise that point. We've also got a new government in place and a new leadership team at the Department of Health and Social Care, and as it happens, 2 of our local MPs are going to be part of that leadership team, with Therese Coffey, the new Secretary of State, and Will Quince will have one of the ministerial portfolios, so we wish them both very well. The Secretary of State has set out a vision, a new direction based upon A, B, C, D. So I'll just touch upon those letters, and we might add a P at the end around pensions. But on A is an emphasis upon ambulance response times, but particularly the issue of ambulance handover delays, which is a major quality issue, which many of us have been involved with. Pleased to report, if pleased is the right word, that within our ICS we benchmark comparatively well on ambulance handover delays, but no, we're not meeting the 15-minute standard. West Suffolk FT is the best performing hospital site in the east of England currently, doing very well nationally, but I really implore the board that we keep a real focus on handover delays and get down to those 15 minutes because it's such an important quality metric. So that's the first thing I'd say. On B, this is around backlogs. So again, a huge amount of work in the system on backlogs. The HSJ recently published an article saying we were the 4th fastest system in the country around elective activity, which is encouraging, but the waiting list is growing across the system, and that's the real challenge we've got. So whilst we're making progress, we're building up a real challenge to work through. C was around care, and there's been a £500 million social care discharge fund being created. Where we had to have the fine detail on that, but we'll be working very closely as an ICB with colleagues in both county councils to agree the most effective use of that fund. And then D was around doctors and dentists, as it was framed, particularly looking at GP services, access to GP services. I think the language now is much more around primary care, but it's framed around GP services with urgent patients being seen on the day and a 2-week standard for all patients, and an expectation that ICBs will take a very close interest in improvement of access. And secondly, around dentistry, and Richard's touched upon dentistry. I think it'd be really helpful, Chair, to bring a paper actually to the next board to set out the many things we're doing. We've got some very exciting developments actually in the pipeline, and there's a lot of national interest in what we're doing in SNE around dentistry, which is great, but we have a huge challenge, and it's a major driver of inequality. So those are the A, B, C and D. The P I would add is that looking at changing rules around pensions. which has provided a perverse incentive for some colleagues to retire early, so to retain our workforce, and also an emphasis upon pharmacy, which we've worked really well with during the vaccination campaign. But the question now is, what more can we do with the pharmaceutical sector and our local pharmacies to improve access to primary care and support all the work we do. The final two things I wanted to touch upon was our vaccination programme, so our COVID booster campaign. And as of today, we are the leading system in the country for the speed of the rollout, which I think Lisa reported on the radio just before this meeting. So we're really encouraged about the progress being made there. And then finally, a big thank you to one of our board members, Nick Hume. Nick has agreed to support the ICBs in SNE and Norfolk and Waveney, as well as NSFT and NHS England, around the mental health transformation work we're doing. And Nick brings, as we know, a wealth of experience and is a visionary leader that really is passionate about patient care. So he'll bring all of those qualities to the table, and we look forward to working with you, Nick, so thank you.
Great, Ed, thank you very much. And with respect to the future paper on dentistry that you mentioned, I saw a lot of nods around the table as Ed suggested that. Shall we take that as an agreed action? Are you content? Yep. Okay, thank you very much. Any questions for Ed at all? And if not, happy to move on. Lovely. Thank you very much. Very encouraging report, Ed, in challenging times. So I think from the board's point of view, we're probably grateful for all that positive news, but also recognising that absolutely we mustn't be complacent. And I know you're not in any way suggesting that we would be or that we could be. So still a lot to do. Good. In which case, shall we then move on to item 7, which is the approval of subcommittee terms of reference. And Amanda, I'm going to you.
Thank you very much, Chair. So since our inaugural meeting on the 1st of July, a lot of activity has continued with updating and finalising the remaining terms of reference for the various subcommittees reporting to us as a board. We have 7 that are presented today for hopefully approval. But before we get into the specifics, I just wanted to identify 3 things really by context. In terms of the varying styles of our terms of reference, I think there could be opportunity to further enhance the way it looks and consistency and the like. And what I would like to suggest to the board is, when we next review the terms of reference for the various committees, we perhaps look to ensure that we have some kind of corporate style, and that's something my corporate team can support with. So that was the first point that I wanted to refer to. And secondly, I think it would be perhaps a good idea that we have some consistency around building in some review dates for the various subcommittees, either after 6 or 12 months. And again, to support that process, my colleagues within the corporate team can actually provide support with regards to that. And then the third point I wanted to make was around the terms of reference that we have regarding the people and committees terms of reference. And those of us that have read would have noticed that we actually stopped midway in sentence and didn't actually finish off by stating who the chair of that committee is. So I'm pleased to report at the moment the chair of our People and Communities Committee will be held by the head of People and Communities Partnership role. So that's something that we need to extend for completeness in terms of that sentence in regard to 5.4 of the terms of reference. In terms of the Procurement Committee, I think, Paul, that you wanted to just add something in addition, didn't you, to the current terms of reference?
Yeah, just so when we began to plan the governance structures, it was a time when we'd got 3 CCGs, and there was a strong feeling that we probably needed a procurement committee to bind, if you want, to essentially 2 procurement processes that were both in place. whilst we're moving into the ICB proper, and I'll talk later about the procurement paper where we've got to in our thinking, there is a bit of a view that maybe we don't need that procurement committee is a first point, because we are now centralising the procurement process, and actually the accountability for procurement lies with the accountable committees. So in a sense, we're keeping our powder dry to say it's in the governance structure. We may or may not need it. The other element of that is I felt very strongly that if we did have one, it would have to be independently chaired. And as there is also a conversation around your name's capacity, it's worth waiting to see whether actually that conversation settles in terms of that future conversation. So I'm hoping for a further conversation on that, but I guess I would bring it back should we need a procurement committee in the future.
Okay. Thank you very much, Paul. So by way of concluding the item, Chair, the terms of reference that we have presented today have been all kind of discussed by the relevant committee and the relevant chair. So they are, as we know, complete at the moment, obviously with the appropriate review period built in, but they are here today for hopefully the board to approve thus far.
Okay.
Thank you very much.
Thank you very much, Amanda, and thank you, Paul. So with those suggestions, we are asked to receive, note, comment, and hopefully approve. Nick?
I can't claim to have read every line on every term. I know that will come as a great shock to many colleagues. I suppose a more general point, if I may, Chair, that we're awaiting the operating framework in terms of clearly identifying the roles and responsibilities between national team, regional team and ICBs. I haven't seen anything, and I just wondered if there was any intelligence around the board as to whether or not that operating framework will change any of the roles and responsibilities at the ICB, and then that will require change of the terms of reference for any of the committees.
Now, let me just see if anybody has that intelligence that Nick's requesting, but if the answer is no, that we don't, we could always still review in the event of influence, couldn't we? Over to you, Ed. Yeah.
You've made the point.
Right. Okay, so should we, are you happy with that approach, Nick? Yep, okay. And Steve?
Not that I don't approve the current iteration, but it's just an observation going forward, really, that I think the terms of reference could perhaps a little differently express what it is we're here to do. So I take the Estates Committee, where our ambition is to help people live in their own homes and to be supported to do so through use of technology and whatever. There's something about how are we building place and what's the Estates Committee role in the place building and shaping agenda. There's something about how we're looking after our workforce and creating environments and conditions for them to thrive and feel safe in the buildings that they're in. There's something about the AFM workforce, the Estates and Facilities Management workforce, whose responsibility is it to look after them? And I would have thought that, given the shortage of those skills, that's something I haven't got much more. There's nothing about sustainability in the circular economy. Whose job is it to drive our sustainability agenda? I would have thought that would probably be somewhere in there. And the final bit is economic growth, that we've got some pretty challenged communities, and the role of the workforce, the role of the Estates Committee to help link across all the partners to make sure we put facilities and jobs in places that are positive. So just reframing as it is, it's quite a traditional terms of reference. I'm really happy to approve, but it feels to me like we should have an ambition in the next 6 months that we start to express the terms of reference of all the committees a little more aligned to what our purpose is.
Yeah, and I see lots of. Sorry, Steve, if you.
No, just and on the People Committee, yeah. I'm listed as a member. I've sent a message a couple of times saying I haven't got time to do that, and that I would appreciate they found someone else as well. That's just a point of if Amanda could pick that up. But the general point I think is understood. Yeah.
So happy to approve, but asking for that conceptual, contextual review to be embodied at the. As soon as possible, but at the next reviews. Yeah, comfortable with that, everybody? Yeah.
Yeah.
So, Steve. Yeah.
Well, I think a bit further than kind of at the next review, if that's 12 months off. I think everything I've heard from everybody who's spoken is about some uncertainties about the environment in which we're operating in, some of the settling of our own enterprise. Getting used to different forms of language that have been inherited from different places. They're slightly different places. We want to kind of make that feel like it's as one. All that suggests to me we need to keep a, well, we need to be looking much more quickly at review, not leaving it for the 12 months. And Steve's referred to 6 months, and I'd go along with that. Yeah. We ought to be looking to get to try and refresh some of that stuff on a much more rapid basis. Otherwise, we just get another year in, and then we're doing it.
No, understood. And again, I see a lot of nods, and actually, for those terms of reference where there was a time period, it was 6 months. So yeah, but most of them were blank, weren't they? Is everybody happy to adopt within 6 months? Yeah. Yeah.
Makes sense.
Good. Agreed. So with those comments, contextualisation and review period approved. Essentially, we're approving them as working documents, aren't we, really? But the board accepting that they're not in their final form. Yeah, agreed. Good. Thank you very much, everybody. In which case, shall we then... So we've dealt with, as you will have seen, the agenda today is in 4 parts. We've dealt with general. We've now got strategy, and then we go on to finance, performance, scrutiny, and then governance and corporate business. So with that, shall we go straight into the strategy section today? And Amanda, I'm going back to you for the Community Diagnostic Training Academy.
Thank you very much, Chair, and I'm really delighted to welcome Peter, Gary and Rob to today's board. And this comes about from our last People Committee, whereby we had an amazing presentation and we felt it was really fantastic that we should actually share it with our board today. So I'm going to hand over to Peter and Gary in a moment, and then Rob is going to come in at the end and share his personal experiences, because Rob was actually a student at one time as part of the academy, and through participation in the academy, you've now gained employment, which is tremendous. So we're really looking forward to hearing more about that in a moment, Rob. And we're also going to, I think, share with you at the end of the presentation the subsequent conversations that have taken place since the last People Committee, where we're now looking to really scale up the programme so that we can benefit as a complete system. So without further ado, can I invite Peter, Gary and Rob to the table?
Yeah, please come and use the microphones. Yeah, absolutely.
Thank you.
Okay, so all yours.
Thank you. So thank you to Amanda for setting us up by saying we did a really good, tremendous presentation last time around, because now we've got a lot to live up to. So there's 3 of us here, and as Amanda says, Rob is now an employee at ESNEFT and has participated in this programme and come through out the other side as one of our substantive employees now. What we're going to present to you is a partnership of a variety of different organisations, principally ESNEFT and Culture Institute, and Gary's here from the Institute. So what I'd like to do is set out what we were intending to do to start with. Some slides which you've already seen in the packs, but I think colleagues in the corner are going to help me run through the slides. Gary will talk about what we then did, and then Rob will be an illustration of what it was like to be somebody that's gone through that programme. I think that from the outset, this was born out of the desire to try and bring to the table some additional resources, some additional people to add to the workforce through the Community Diagnostic Centre that I won't need to go into a huge amount of detail with yourselves, that was set up in Clacton. And if all we were going to do was just take our existing staff and then spread it even thinner, then it would not give us a huge amount of benefit. So that this was a kind of part of a contributory factor to try and build a wider workforce. Initially to try and get people into entry-level roles, but then use that as a stepping stone to start to develop more locally homegrown senior specialist skills. So can I ask you to start the slides, please? So that's pretty much what I have just said. The outset, we were looking to try and help contribute towards a great workforce for the Community Diagnostic Centre, or hub at the time. That came into being in July 2021. we set out to try and get some funding to put a program together to coincide with the opening of the CDC. It was subject to government funding, and as with a lot of these things, it took quite a lot of time to get answers back from the funding pot, which meant we started in November. Next slide, please. So, as I said, this was a joint venture between the two principal organisations, but also working with DWP, job centres locally, and the National Career Service, and it's part of a longer-term ambition to grow our own, which I think is a phrase that I hear often around tables like this, and certainly in my own organisation. The aim in the longer term was to physically develop a presence at Clacton, and we've got a training facility going in there now. I call it a training facility, that's probably an exaggeration, but a new training room there, and Culture Institute are busy moving in alongside us in terms of their own local learning shop and moving it from probably accommodation that wasn't really fit for purpose into something that is going to be more attractive for the local population to come and use. We applied for funding through something called the Community Renewal Fund, which came out of the what was the Levelling Up Communities local government department, and the focus of that funding was on Harlow and tendering. So the tendering bit really neatly fitted into what we were doing. And as I said, the initial focus was on those entry level roles, band 2s, band 3s, that we needed to support. Next slide, please. So in the bid, we said we would do the following. So we said that we would work with 133 adult participants. I'm not sure where 133 came from, is an odd figure, but we said that. And of those, we would support 90 people into employment. That's been adjusted slightly, of which 50 would be into NHS roles. Obviously, we were focused on ESNEF at the time, but there's two angles to this. One, the benefits to the organisation, but secondly, regardless of where the person went into in terms of employment, you know, I think everybody's been in conversations around the importance of employment in terms of quality of life and helping to address health inequalities, etc., etc. So we feel success is not just somebody to come and work in the CDC, not someone just to come and work in the CDC or in ESNEF, but somebody in employment, and we think that's a really good outcome. I won't go through all of those words, but I think I know Mr. Fairley over there from a previous existence, and we both worked in economic development and in the world of employment programs in the past. And a lot of them are well-meaning. A lot of employment programs through things like European Social Fund have come and gone, etc. The difference between this and a lot of those is there's jobs. So at the heart of this is there are real jobs, real outcomes for people, rather than just putting people through employability, soft skill training, etc., and then leave people hanging at the end of it. So there's been a real opportunity here. Next slide, please. So we wanted to do several things. One of which is to help people into employment, and I've talked about that. Secondly, was to look at that stepping stone and what people might need, what might be able to go on to. So we were very interested in exploring the potential for appropriate apprenticeship standards to enable people to go into diagnostics further up. So we want to develop the radiographers of the future. So we wanted to investigate a new trailblazer apprenticeship standard, and Gary will talk about that in a minute. And we wanted to use the program to help inform the curriculum that's being delivered locally for our health and care students. So and we're replicating this stuff at New College as well. We've got through the institute something in the region of 200 students, 16 to 18-year-olds typically, who have expressed an interest in working in our sector. They're on BTEC courses currently, level 2 and level 3 in health and care. There'll be T levels at some stage in the near future. So the question was, how are we capturing those? How are we helping to inform what they're learning, so they're learning the kind of things that we need when we accept them into employment locally? And are we doing that enough? So part of this was also about supporting the institute. We commenced the programme back in November last year. Seems a long time ago now, but so we've only been going about 10, 11 months. The funders of this, via Essex County Council, are very, very pleased. You see this as probably the best of the projects they've funded across Harlow and tendering. We've got more than we more participants than we anticipated, and Gary will talk through the numbers. About 80% have been from tendering. We haven't been dogmatic about this. The rest of them have come probably from Colchester Borough, and about half of those people have come from a background of being unemployed. So that's what we set out to do, and I think that if you go to the next slide, please. Hopefully that's now lines Gary up for what we did.
Thank you, Pete. Good afternoon, everyone. On the screen there you can see our original flyer that went out on social media channels and through local traditional newspaper advertising. And there's no doubt at all that that hook of the guaranteed job interview, the opportunity of work placement in a real life working environment such as the CDC environment really produced some staggering results. If we can go to the next slide, you'll see that remembering our initial target of 133 participants, absolutely smashed that. 236 people were invited onto the programme, of which 169 are currently still active with us at the moment. And then you can see a further breakdown of where they are at in terms of their stage in the scheme itself. We're showing 40 there in jobs at present. It's actually 42 since these slides were produced. 23 are actively employed by ESNEFT, and 19 by other organisations at this stage in a range of roles, both on clinical and non-clinical areas, such as Robert here, radiography support officers, HCAs, physio assistants, pharmacy assistants, receptionists, booking clerks, associate practitioners. The list goes on. It's been a wonderful testament to working in partnership. But the work isn't finished, of course, because we're aiming to make sure we hit that employment target. We've got 62 of our participants currently actively job seeking, and you can see it there. 22 currently in further skills updating, and 45 still on the course itself, still on work placement. So there's a long way to go with this, we're absolutely delighted with the output in terms of comparison with our normal programmes aimed at the unemployed. This really was a fantastic response. Next slide, please. This is just an image of an early cohort there. You can see the candidates with their certificates after finishing the master classes. And workstream 2, Pete referred to there in terms of the apprenticeship development. We did undertake a level of research with a number of foundation trusts. We found there was limited appetite for a standalone level 4 apprenticeship in diagnostics, but we have made a contribution to the level 3 senior healthcare worker standard in terms of inputting a new diagnostic route for that particular apprenticeship standard. So there's some positive output from that work stream as well. Lastly, work stream 3, we are entirely grateful to colleagues at ESNEFT for contributing to our curriculum development at the college. As it says on the screen there, we've been able to replace some modules within our course programme to better align our provision to what the hospital needs in terms of their future workforce. So without further ado, time is against us. I think I'll pass over to Robert to give you a bit of an idea of what it was like actually on the programme.
Yeah, what it was, I'm an accountant by trade, and found myself out of work just before the pandemic, and I didn't really know what I was going to do with my life. I then lost my mother to pancreatic cancer, and I really didn't know where to go, and luckily by chance at the job centre I was introduced to this course, and the first question they asked is, did I want to do something business or clinical? And I thought, I've worked in business all my life, why not do something clinical? So when I actually started the course, I was quite surprised that I could do something that I've never done before. And with the master classes, which sort of give us a basic understanding of what we're going to do. But the main thing, which was very interesting, is when we were actually out on placement, we were able to go to so many different departments and see exactly, you know, what you can do at a hospital. And I think there's a lot of talented people who would never even think of joining the NHS. And I think that's what this course did for me. It sort of gave me a chance to do something which I'd never even think of doing. At first, I thought I'll do admin because I know it, but to be given that chance to do the clinical side, it was amazing. And then finally, after going on the different placements, I was given an interview, and I got the job of a radiology support officer. So my next aim is to work my way up. I'm a band 2, and one day I'll be a band 8. And you're never too old, because I'm 49 now, and I thought, you know, changing careers at such an older age, can you do it? I think it does take some balls to do it, but, you know, it can be done. And I'm not going to stay at band 2. I will work my way up, whether it be as an assistant practitioner or even some sort. If there's some sort of funding to help, once I'm in the NHS now, but I'm willing to sort of build from where I've been given this chance. And I think that's the main purpose of what we're doing here now. Thank you.
Thank you. Which I think brings back to me. So that kind of leaves us with a question in terms of what next. So there's several strands of this. So there's firstly a job to do with what we started. So we've got 40 something people that we've still got on the programme. We've got a number of people that we're actively helping to look for employment. So this isn't where they finished and they just get left alone and we hope that they answer an ad in a newspaper. This is, you know, we're on the phone to them, we're supporting them with their job applications. There's a promise of a guaranteed job interview at the end of the programme by participating. Not necessarily a job, but a job interview, and then they've got to, you know, compete with others. So we need to continue and finish off the cohorts of participants we've got at the moment. There's exactly what Rob's described. Rob was saying earlier that he'd like to be a radiographer. So there's a job to do in terms of having secured people into employment at ESNEF. We need to keep them, and so there's a kind of retention issue there, and how we might use the likes of apprenticeship standards to provide a pathway funded by us as an employer through the apprenticeship levy to get people into those roles that Rob aspires to do. So there's the kind of let's finish the job we've started, but there's also an opportunity for us to expand this to other environments and other geographies. And so Amanda's team, Gary and myself, have been looking at the potential opportunities elsewhere. We've had conversations with Andrew recently about some of the more ambitious kind of things that we might do. At the moment we're looking at potentially replicating what we've done around the Diagnostics Academy at Ipswich and in West Suffolk. And we're also looking at, in Colchester, targeting not a job area but a community of people. So we've been engaged with the armed, various representatives of the armed services in Colchester and with I think it's called the Career Transition Partnership, and we've agreed with them to explore the potential for something not dissimilar to this, but actually focused on the family dependents of armed forces personnel and veterans, and look for what they believe are the kind of roles that they would be interested in around clerical administrative type functions. So the common denominator would be still intensive support, work placement opportunities, master classes, but the jobs at the end of it would be slightly different and the content of those would be slightly different. But we believe that there's an opportunity here to do this on a number of occasions elsewhere around the footprint with support. Thank you.
That's great. Thank you very, very much. And what an inspirational story, or actually stories, isn't it? And hitting so many buttons as well. Frida, shall I come to you first? Yeah.
Yeah, I just want to say thank you for your presentation. As the chair said, it's very inspirational and it's fantastic, actually. And Rob, listen to your experience and how you went from unemployment into employment and you're actually enjoying it in the NHS is just really inspiring, actually. I just would like to say that in terms of general practice, where are you? Can you come to us as well? Because, you know, there's a huge workforce issue as well in general practice, and with the recent announcement by the new Secretary of State, there's a role called GP assistant, which I think we're all trying, as GPs, trying to work out what that means to us. I should imagine it's an administrative role with partial clinical experience from what I've read. So it would suit this curriculum really well. So I'm just wondering if perhaps that's something that we could discuss with yourselves, and because I think we could utilise this, particularly with the funding that's offered for GP assistants now. It's just literally come out this week. But thank you, all of you.
Yeah, thank you, Frida, for that. So I've got a great long list here of people who want to contribute. So if I could, whilst recognising the importance of this presentation, this item, if we could keep it sharp, that would be helpful for time management. I'm going to go to Ed, Richard and Stuart, and then further down the list. So Ed first.
Great, absolutely inspirational, so thank you. I'm the co-chair of the Essex Anchors Network, so definitely let's think about SNE, but also obviously Essex too, because I'm thinking there's probably community diagnostic centres being set up in Mid and South Essex, for example, and can they learn from what we've done in Clacton, in the wider Essex as well? So if we could just think Essex as well as SNE, that would be really helpful.
Yeah, good point, Ed. Yeah, Richard.
Similarly, incredibly exciting and lots of potential with this. Two thoughts. One is, I guess, the linkage with DWP, whether we could do more with them directly. And colleagues nodding to a few of us were with one of our local MPs yesterday, where we were talking about the economically inactive, not just the unemployed as well. And I think there's ways of leveraging funding out of the DWP, possibly to support this. I'll link up with you, Amanda, on that. And I suppose for me, a bit similar to Frida, mental health. So is there more we could do, actually focus with EPUT and NSFT around this, given we know we've got challenges in workforce, but in all areas, but particularly mental health as well. So if we could link through with EPUT and NSFT, and again, happy to help with that, we could look at doing something with that. We've got funding opportunities, I think, that could help with that. But well done.
Thank you, Richard. And Stuart?
No, indeed. Well done. I think one question for me, which is that I suppose those people who came on the programme, how far were they away from the workplace? I'm just trying to think about that point that Richard made around kind of inactivity from a workplace perspective in that sense. And the second one, I think definitely around that scale-up piece. I mean, obviously within Suffolk, we're talking about still about a county deal and adult skills. And I think, again, it is about bringing these things together and looking at both the challenges that the health service have and care sector have from recruitment, but also building on economic assets within communities. So really is quite exciting.
Do you want to comment on that?
Yeah, just in terms of the first question, I think the obvious answer is it's varied, but I'm not going to comment on the individuals, but I went to sit in on one of the master classes with our director of HR, and we heard stories from some of the participants who opened up about being recovering alcoholics, recovering drug addicts, etc. So there was a broad sweep of people from very different backgrounds.
Great, lovely, thank you. I'm going to go to Tanya, Amanda, Peter, and then Steve Feast, and then we'll try and draw this to a close. So, Tanya?
I'll try and be brief. I'm really curious about young people from disadvantaged backgrounds and thinking cost of living crisis really hitting hard is going to hit our deprived communities even harder. What's your attraction strategy, if anything, to actually get those young people into work?
So I could have bored you all afternoon if you wanted to hear all of the things that we're doing. So this is kind of one segment of a wider programme of widening participation that we're working with the Institute and other organisations on. So we've got a variety of different programmes through masterclasses aimed at schools, so Year 9 upwards, where we're targeting schools, particularly from disadvantaged areas, to interest them in careers, and we're second week into a AHP series of masterclasses at the Iceni Centre at the moment with school children from Cultural Academy in Colchester, and we've got a range of work experience opportunities. So as an F that we're aiming for 500 work experience opportunities for school students at our trust over the course of the academic year. We've got the work placements for FE students from the Institute, and we're replicating that with Suffolk New College, so probably about 60 to 70 from each, and dedicated activity with the schools that serve our disadvantaged communities. So we're trying to bring two things together, the kind of practical and what we say in reports that we're going to do, and actually target those schools, the likes of Claxton Coastal Academy, etc., who have now got on their doorstep a brand spanking new community diagnostic centre which could inspire them.
Thank you.
Great, thank you very much. Amanda?
Thank you very much, Chair. So it's really a question for Rob, but I don't expect an answer, Rob. But given your brilliant presentation, and thank you for sharing your experience, it was really, really good. You may wish to consider becoming a mentor for our future employees who are coming through the academy.
I'm already a mentor, I think.
Brilliant, because we know that it's great recruiting, but equally we need to be retaining, and I think you would be perfect. So just consideration.
Done. It's a done deal.
Done deal. Well, that's it. We'll minute that then. Peter?
Yeah, thank you. And to echo, it's a fantastic project and a great outcome, so well done to everybody. So some thoughts on some of the questions in there. Would say social care as well. We've got huge challenges. The NHS is a great brand. For those that don't go on to get a job in the NHS, is there a way of making the connections into care? To build on Ed's point about the geography, Braintree, I think, is a relevant geography for you to think about. We struggle for people in there, and in terms of some of the job market, and yet lots of people in Braintree go into Colchester Hospital, and Colchester in turn depends on the market there as well. So, and finally, we have a Nightingale Care Bursary as well, funded through the County Council as well. So again, there might be some links for us to synergies to promote there between the two.
Brilliant, thank you very much. Well, that was a really great presentation, all three of you, fantastic, and great comments and adoption of the mindset by the board. I mean, I think the board is basically saying that hits so many buttons for us, from growing our own workforce to the wider determinants of health to personal health and well-being, aspiration, helping drive aspirations and so on. It just hit a lot of our buttons. So I think we've got a lot of actions there. There may be more post the meeting as well, which you're welcome to send in. I'm sure, Amanda, you'd be happy to receive. Let me come to Ed before we close.
I just wanted to make a point.
Oh, sorry, Steve. You're absolutely right. You were on my list. Yes, go on.
I mean, I just wonder if what we're hearing here is a more fundamental approach to how we bring in a workforce. So we've got vacancy rates all across the organisations, which is a sum of money that probably adds up to a huge sum of money. As chair of the Quality and Safety Committee, the most pressing issue we are hearing is workforce continuity and conditions. We reframe that public services are not a bad place to work, but a great place to work. And we go to our population and say, it doesn't matter whether you've got 5 GCSEs or you've trained as a radiographer, we will find you a way in to public services. And then we will help you navigate your roles and certificate you and get you into those roles. I think this is something that could be done as a collective action. And if you link it to the fact that a lot of our staff, through mental health and wider burnout issues, are given a binary choice between working and not working. Imagine if this was working well and they could actually say, I don't want to do the role I'm doing, but I'm very willing to do a different role. So how do we have a front door that is universal and open, a middle bit that helps people and works across them? Because we are now an integrated care board with a lot of very expert people and third sector and other organisations, but also addresses its attention to our existing workforce in offering them more flexible careers.
Yeah.
That's something really big to think about.
Yep. Good points, well made. And apologies for missing you off my list, Steve. Thank you. Ed?
Yeah, it was just a conversation around the capacity we may need, because we've thrown at you. We want to scale it up. We want think social care, think mental health, think primary care, think Braintree. You know, there's a long list we've thrown at you because we've got a winning formula. We want to apply it elsewhere. So let's maybe have a think with Amanda about how we scale up the capacity to support you to to make this a bigger...
I think the starting point is having the ambition, and I think, because I think all of these are possible. I think, it's just having the ambition and the drive and creativity, and I think we can do these things.
Yeah.
Skills for care and skills for help used to do this stuff quite well some years ago, but that's still around.
Yeah. And I think the sentiment of the board, correct me if I'm wrong here, is that we love it, we want to invest in it appropriately and do more of it with more outcomes in all the ways that you described, not one particular way, but all those buttons. So with that, we were asked to consider how to roll out, or if it was rolloutable. Well, I think the answer to that is yes, yes, and yes, isn't it? Let's do it. But we were also asked to celebrate the work that had been done so far. So perhaps could we take the opportunity to thank Pete and Gary and Rob for a fantastic presentation and the work. Thank you very much.
I suppose I should be honest and say that the two of us haven't really had much to do with it. We've got very good teams that have done all this, and it's their hard work.
Understood, Pete. Thanks, and thanks to all involved. Great, and you're welcome to stay, by the way. Or
I've got a hard taskmaster.
Yeah, I'll bet. Yeah, I'll bet. So I'm going to keep. Thank you very much, guys. So I'm going to keep this moving. Amanda, did you want to add anything else, or is that closed, that item, from your point of view?
I think we've closed it. Thank you very much, Chair.
Okay, in which case let's move on to item 9, which is the ICP update. Susanna.
Okay, so have you ever heard the term follow that? I have the unenviable task of following that. So this is just a very brief update from the Suffolk and North East Essex Integrated Care Partnership. So the paper sets out obviously some of the background which the board will have heard before, that the ICP is the second part of the statutory arrangements for the Suffolk and North East Essex Integrated Care System. So it's a statutory committee jointly and equally convened under the Health and Care Act by the ICB, but also Suffolk County Council and Essex County Council. It's co-chaired by yourself, Professor Pope, and also Councillor Reid and Councillor Spence. The ICP met for the first time on the same day that the first meeting of the NHS Integrated Care Board took place. That was at our Expo 2022 event at Newmarket Racecourse. So we put in place the basics, the Memorandum of Understanding and terms of reference for the ICP and its membership. We've got an area on the ICS website that features all of the papers and also provides links to the meetings for members of the public. In July, at the end of July, we received national statutory guidance from the Department of Health and Social Care, which set out in more detail the expectation for integrated care partnerships across England to put in place integrated care strategies for each integrated care system. And the importance of the integrated care strategy is that it will set out how commissioners in both the NHS and local authorities, working with providers and all partners, will develop more joined up, preventable and person-centred care for the whole population. So just in terms of an update on our ICP, the last scheduled meeting of the ICP was actually scheduled for Friday the 9th of September, and very sadly this was the day following the death of Her Majesty Queen Elizabeth II. So as a public meeting, that meeting did not take place on that Friday. What we did do was to meet the three co-chairs and myself to review the agenda items, and the majority of those will be carried forward to an extended meeting which will take place on Friday the 14th of October. What we did do was to ask members of the ICP to review one paper in particular and to ask for their approval of that virtually, if you like, by email, which they did, which was the paper which set out our plans for how we're going to develop our integrated care strategy for Suffolk and North East Essex. So that paper has been approved, and what we did this week is to launch the public engagement phase of the development of our integrated care strategy. So that's framed around a couple of kind of big but really important questions. So the first is the question, what matters to you and why? And the second is, how should we be thinking differently as a health and care system? We've set out a number of ways in which all stakeholders can engage with the integrated care system around those questions. So the first is some online Thinking Differently Together events, which are going to explore 3 themes of belonging, safety and purpose, which are the ones put forward by Dr. William Bird, who's the chair of Active Essex, and he gave a keynote address at our Expo 2022 event, which really kind of caught the imagination of a lot of stakeholders in the system. The second is that we've set out a schedule for a series of stakeholder workshops which are going to take place during October and November, where we're going to bring together people with lived experience, clinicians and professionals, those leading local strategy. We're going to draw data from particularly our joint strategic needs assessments in Essex and in Suffolk, and also look at any kind of expert evidence as well, and to bring that together into a conversation around those 2 key questions: what matters to you and why, and how should we be thinking differently. And then drawn from that, we'll be able to start to set out, if you like, set out our stall in terms of a strategy from the perspective of the people we serve in our population in an outcome-based approach. The job for the Integrated Care Partnership then, building on that, will be to consider from that, if you like, the priorities that we need to set as an integrated care system. When we have a steering group who are currently working up a methodology to identify those priorities. Just to finish off, in terms of patient and public engagement, it's a very key role for the Integrated Care Partnership to provide a whole multiple range of ways to ensure that every voice in our integrated care system is heard around our strategy. So we're working with Healthwatch Essex and Healthwatch Suffolk very closely around development of the strategy. In fact, Healthwatch Essex are going to be seconding a member of their team into the ICP to help with some of that analysis of lived experience. And also we've reached out to, in particular, voluntary and community sector partners to ask them if they can help us to support by holding community conversations around the key questions around our engagement as well. And last but not least, our pop-up video booth, the Inflator Pod, is going to be making 12 visits around Suffolk and North East Essex during October and November, so that we can actually kind of hear from people directly and include that information as part of our the way we set out our strategy. So we're now live. We're running as an ICP. We've had a little bit of a delay in terms of our meetings, but the work to develop our first integrated care strategy is well underway. Thank you, Chair.
Thank you, Susanna. We are, as a board, asked to note and support, if we're so minded, the engagement as proposed. Any questions for Susanna? And are we happy to note and support as requested? All done. Thank you very much, Susanna. In which case, let's rapidly move on to the PHM strategy. Richard, over to you. You've got 5 recommendations, in fact, to adopt here, haven't you?
Indeed. Colleagues hopefully have had a chance to have a look through the paper. I'll just give you the highlights and point you to the section. So it's section 1, just briefly, by way of background, and apologies to tell those to suck eggs, but there's a brief explanation of what population health management is. It's about using linked data to provide new insight and then taking linked actions to improve social, physical and mental health outcomes and the well-being of people within and across a defined population. As section 1.3, as always, NHS England have got some specific requirements for ICBs, particularly in this area. So you'll see the first one, which is quite technical in nature, and I'll come on to it a little bit more later in the paper. By April 23, we need to have in place the technical capability effectively to conduct population health management. And the main element of that is a longitudinal linked data set. Again, I'll come on to that. I'm not a technical expert, so I'll get it down there now that if there's technical questions, Stuart will be able to answer. By 2025, each ICS will effectively be utilising population health management to inform their strategic decision making. I'm hoping we'll be well in advance of 2025, given where we currently find ourselves. So turning to section 2 at 2.1, as the Chair's just alluded to, we have developed a population health management strategy. It's been co-produced by a variety of different partners, including many around the table here, all your organisations. It actually was drafted back in January. We've done some further tweaks, but it's broadly the same as was developed back then. It was due to go to the ICP, as Susanna's alluded to, at the meeting in September. We're now going as part of the 14th of October to take that strategy there. So it's the ICP that will be signing off the strategy, but obviously it sets the context for this wider paper day in terms of how we're looking to take it forward. We will be sharing it with our neighbouring ICSs. So we do have a regional population health management group that we're represented on, and so we are sharing and comparing the work, particularly within the Essex and the Norfolk context, because obviously we straddle into the other counties as well. Section 2.2 is the data set, so that linked data set I talked about that has to be in place by April 2023. We carried out an options appraisal following the the ICS Partnership Board, earlier incarnation agreement, and an organisation called Agilicis supported us on that. That recommended originally that we focus on the two organisations that actually were in our patch, which was Cerner and NEX. Following then a procurement process, we've got to the point of award of a 2-year contract to NEX, which is using what's called an Axiom platform. Again, that's really the technical detail of the side of things. There is an operational group now being stood up to actually take forward the detail of how that will be put into place. But we're currently working to mobilise that, and we're confident we'll have that in place by April 2023. Just briefly turning to governance at section 2.3, we've refreshed the governance arrangements. Now we are the ICS and the ICB more formally. We have a PHM strategic group that Andrew and I will be co-chairing. We've had one meeting, our second meeting is on Monday, and that's bringing together, again, all the main partners across the ICS around the agenda of PHM. It's particularly looking not at the ongoing development of the strategy, it's making sure we're delivering it, and particularly it's an opportunity to bring the different partners together to review the work that's happening through the 3 alliances, some of the cross-cutting work where it makes sense at county and ICS level. So it's looking at all of the different programmes of work in particular. That group, where there was no perfect way of this, but we're looking for this to report into the SOAC. So we really struggled with what was the best committee within the ICB governance. Looking at our neighbouring ICSs, they're pretty much all going through into their performance-based committee. Now, PHM is much broader than performance. You could argue quality, finance, everything, but we needed to anchor it somewhere. At the same time, we've put in place an operational group, which, as it says on the tin, which is very much focused on the mechanics of PHM, how we get it all into place, and that's reporting through to our 3 alliances as well as the strategic group. Nearly there, section 2.4 is the resource. So we do already have resource in place. It is broadly part of day jobs of a number of people, particularly in North East Essex and West Suffolk. So we are looking for some additional capacity, and you'll see at section 2.4 that the executive management team for the ICB has endorsed a decision to come today to release some recurrent funding, both for clinical leadership, a small change function that would work across the 3 alliances, and some analytical capacity. And the details of that are in that section 2.4. And then just finally at section 2.5, we also have a high-level roadmap, which is effectively setting out some of the main aspirations, main things we need to do over the next 2 to 3 years, and that can be found embedded within the main strategy. So I won't go through the recommendations, Chair, but effectively that just gives you a bit of a flavour of the work that's underway.
Thank you, Richard. Thank you for doing that so expeditiously as well. I was hoping also to not have to read out all the recommendations. Shall we go, first of all, for questions, if there are any, for Richard? Steve and then Nick.
I kind of gave you notice of this earlier. When I read this paper, I just came on the back of reading, or not reading, chairing 17 awards to industry, and I was just really struck that most of the bids through there have been saying we are building an intelligence function in order to map to the existing knowledge we have about the challenges, the McKinsey waterfall charts, etc. And it just strikes me we could end up learning more and more about our population whilst not actually bringing it to bear in terms of saying to partners, how do we turn this information into intelligence? And then what are the targets internally and across this board we will set that say that we'll either get more for the money we're spending, or the spend will go further in terms of inequalities, or we will save money that we can redistribute. And it just feels to me that kind of commercial aspect is missing from this, if you like. I mean commercial in the widest sense.
Yeah, and Steve, sorry, my words, not yours, I appreciate it. Are you perhaps, are you basically saying it's great, but don't be too academic about it and be outcome focused? Is that...
As you know, I worked in policy in public health and population health management for a long time, and it strikes me that we've got very good in the last decade at telling people how awful their lives are, and producing more and more exciting charts of that misery, rather than actually saying, here are co-productive ways in which we can work with you, and this is how the intelligence is going to be used for those that provide services for you, or with you, should I say, that will actually have a difference. And I think we just need to turn that into a cycle that is reported in a hard way to the board.
Excellent, thank you very much. I'll just hold you, Nick, if I may. Let me go to Stuart first.
If I make
a start, is that
all right, Chair,
yeah,
and then Stuart will come in.
Yeah.
I think you're right. It shouldn't be seen as a panacea, although often these things are seen as that. I think the art is what we're going to do with the information that we get, and how does that influence strongly our strategic direction, linked to the previous item on our ICS strategy and our joint forward plan that I talked about at the last ICB. And actually, I do think this gives us a really good opportunity to really understand our population, and also to better plan moving forward, particularly it bleeds into the next paper, I know, Steve, in terms of the question, but particularly that advanced analytics and the health economics element of it, we can better predict what that demand and what the particular interventions that we need to make. And particularly, I think the bit that we've not done as well on is actually the evaluation end. So again, it bleeds into the next paper, but we need to get better, I think, collectively at evaluating, reviewing in terms of what interventions we're putting in place and what the outcomes are that we're seeing as a result of that. So I think we need it, but I think it's incumbent on us all, as you're saying, to actually use what comes out of it to inform us and what we do.
We used to have those value reviews, if you remember those, how would this map to the benchmark value?
Excellent, thank you very much. I'm going to go Stuart, Nick, and then Frida. Stuart?
I wouldn't disagree with what you said, Steve, but I think the bit for me is the way that this has been grown, which is that it's not just public health writing some big reports at the top, it's also being worked with GPs and clinicians on the front line and actually looking at what is important, what are the cohorts, what are the groups they're working with, and looking at and understanding their patients in the whole. So I think it needs to be from a strategic perspective, but it's also from a very operational frontline thing, which I think takes it from a report saying this is a story to actually the stories are important, but also this is working with frontline clinicians to actually use that information to actually generate new ways of working as well. And I think that's, with the cohorts we've seen and some of the pilots we've done within the Suffolk part of SNE, has actually really brought people around the table to have those conversations and to look at things in a different way.
No, thank you for that, Stuart. You're actually asking us to be joined up and integrated, aren't you? Susanna, was yours on specifically on that point?
It was. I mean, I think it's a really good point, Steve, and maybe something we haven't made enough of at the moment is that we've held a couple of learning events through the Thinking Differently Together series. They've been our best attended. There are links to them in the paper. But at those, we shared those examples of how PHM have been used, particularly in primary care, to really make a difference. So maybe what we can do is make more of those stories, as Stuart says, about bringing that to life a bit more. But some of the data's there already.
Thank you. And Nick, sorry to have held you. Over to you.
Thank you. I just wanted to make a point of clarification, really, but also being a GP in the West, I'm aware that already, as Stuart's just said, we've had some population health management done at the very smallest level, at INT and PCN level, as well as in the East, which has been really interesting, and I'm a big advocate for it. But also being a West GP, there's also pre-existing population health management, which was one of the bidders, and I just wanted to really clarify that this supersedes and or pulls together existing population health management, rather than GPs having to share their data more than once, which is, I know, a big concern on the ground of individual GPs.
I will bring Stuart in as well, but I think we've got the operational group meeting. I know we've got the meeting that we asked with you, Nick. I think we need to clarify all of that rather than me try and attempt to answer the technical detail. We do have a challenge, as you're alluding to, in that we had 2 products within our local patch, and moving to 1 does create some challenges. West Suffolk FT we're working with closely to understand how either we can work with both. I think it's likely to be both, but clearly that then has implications into primary care. So I know Julie's been in touch to try and get something in place to really work that through. Stuart, is there anything you wanted to add?
I mean, I think that with the solution that's been commissioned, it means that actually it's already working with one of the national, sorry, my brain's not working today, commissioning support units who can already automatically extract all the information, so the data sets are there. So in that sense, it won't be creating additional work, but it will give us one complete data set across the whole of the patch. So it shouldn't create tons and tons of work. That's the beauty of what we've commissioned in that sense.
Okay, thank you, and good point, Nick. Thank you for making that, Frida.
Yeah, I just, as a technophobe myself, Richard, the thing is that across the GP, a lot of this information will come from general practice, primary care, and we're quite inequitable in terms of our data, I would say. And how would you assure accuracy of data extraction? Because, you know, we're not, I think primary care historically has not been very good in terms of data, and necessarily maybe we're better, I don't know, but I worry about the accuracy of what data you're going to get from us.
Again, if I can plead the fifth and take that one up with the team in terms of coming back to you, Frida, but I know within North East Essex we've got most of the practice data has been sucked into the existing Axiom platform. The accuracy of it, you're right, will be a challenge for everyone. I don't know, Stuart, as my technical expert, whether you can add to that.
Go on, Stuart.
Yeah, I think you've summed it up perfectly. It will start messy, but that will then help to develop and grow and to refine that information as well. So I think people, the analytical teams go in with their eyes fully open, but that's also about why working with clinicians is really important, to not start to make assumptions. But I think we have to start somewhere in that sense.
Yeah, and can I just add that you need the comms to the primary care as well, because we're very defensive.
Not at all, not at all. We do have as part of the, so part of, we're bringing it here for decision ultimately, and then we are looking through the operational group of a clear comms plan, particularly out to primary care, and that will be slightly more nuanced for the reasons Nick's given around the fact we did have or do have another platform already in the West.
Okay. So with those really helpful, positive comments actually about this is a journey, isn't it? The board, I think, today has to ask itself, are we supportive of the 5 recommendations? It is 5, isn't it? Yeah. 5 recommendations to enable that journey, which actually we're not at the very beginning of, but which we're part way through, but we need to complete, if indeed it's ever completed, if it's an ongoing journey, isn't it? But are we then, with those comments that colleagues have made, are we content to support, and I'm just hoping you can save me a job here, all 5 recommendations on block, or do you want to go through them? Support all 5? Nods? Yeah? Okay. Good.
Would it be possible to have some sort of follow-up at some point, say in 6 to 12 months, that says, how is it having an impact?
Yeah.
That's what I'm trying to say. So we moved from building the machines to actually we're really proud of the fact that 30 people with heart failure were identified earlier, or some impact.
Perhaps Steve as well, maybe Richard, do respond to this as you see fit, but maybe 12 months might even be a little bit long, perhaps an interim after 6
Yeah, I'm happy to do 6 months. To be fair, as Susanna said, we've already got cogent examples now of some of the positive ways this has influenced and impacted on people's lives. So just what I don't want the board to, as Stuart's alluding to, and the chair, that we're not starting from scratch. We've already been on this journey for some time, but 6 months seems reasonable.
Excellent. Thank you very much. All agreed? Marvellous. And then, Richard, you're on a roll here. So, intelligence function, 4 recommendations.
Yeah, I've done them Lesby this time, Chair, so there's only 4.
Yeah.
Maybe it'll be 3 with the next one. I don't know who's after me. So, in terms of this, they're 2 papers. We deliberately brought them together because they're very much interlinked, partly as Steve's question, I think, highlights. So, again, this is incredibly technical for someone who's not particularly technical, so bear with. This one relates to the setup of an intelligence function across ICB. So again, at section 1, you'll just see a little bit of detail there about partly where this has come out of. So the expectation is from, we've just passed it, April 22, systems will need to have smart digital and data foundations in place, and effectively that we're starting to cultivate, not my words, an intelligence function across each ICB. And I'll explain a little bit more about that, what that means as we go through the paper. NHS England produced some draft guidance back in January about what that meant. So anyone who's interested, happy to send it through. It is actually quite helpful just to give you a flavour of why they feel, and we feel that this is useful to do. At section 1.4, again, the predecessor body, the ICP Partnership Board, endorsed the need for an options appraisal around the best way to take this forward. And the same organisation that worked with us on the previous item also supporting this, which is Agilicis. You'll see at section 2 that the final report was presented in June, and you'll see the 7 recommendations that Agilicis set out for us. I won't go through them all, but the paper effectively then goes on to start to unpack some of those about what we've done since that point in time. I think the key one, just to highlight, key couple to highlight, is that we implement number 3, a hub and spoke model across the ICS, recognising that many of our partner organisations, including those around the table, have already got business intelligence functions to a greater or lesser degree within their organisations. So we're not starting from scratch. You'll see further down that we set up a task and finish group across the system to support us on this, and they came up in that italics at page 122 with a mission statement, again, which I won't read out. And we also recognised some of the specific components that we needed to put in place, such as analytical leadership across the ICS, health economics, and as the previous point I made to Steve's question, evaluation being a key thing that I don't think we do hugely well as a set of partners together. Moving down then, just a bit more detail at page 123 about what the hub and spoke model would look like. The expectations on the spokes, so organisations that would then work together, you'll see there's numbers 1 to 7 around effectively how the different organisations need to work together, increasingly around business intelligence and intelligence more broadly. Moving further down onto page 124, I think the 2 key aspects today was the funding and the hosting arrangements. So on the funding, we basically said we had looked at 3 options. Do nothing, so effectively ignore the national guidance and carry on as we are now with quite a fragmented set of intelligence teams across our different organisations. The ICB fund the intelligence function or identify a contributing funding model. And we've gone somewhere in best endeavours between numbers 2 and 3. So you'll see that in the paper on the next section, we're looking to put in about just under 400,000 seed funding on a recurrent basis to the hub that we're looking to set up. But it will be also a contributory model by the fact that we've already got, as I've already alluded to, teams across the ICB who will work increasingly together. In terms of the final bit is around the hosting option. So who and how would that hub be put into place? Again, the Task and Finish group looked at the options, and Agilicis did. One option was the ICB itself do that. Another was one of the other organisations within the ICB. We outsource it, or a very bizarre option, a hub of hubs. So where we've landed is actually that we felt that it was better placed that we went out to the partners within the ICB for expressions of interest. When we've had a number of expressions of interest, including from some partners around the table, and we're now going through a procurement process to effectively make a recommendation back around who we award that hub to with that seed funding. Now, just to be clear, they are they're not the kind of the master of intelligence then across the ICS, but they are the coordinator who will support across the different organisations. So we're due to conclude that hopefully in October, and we'll bring back probably under the actions chair the outcome of that, if that's okay. So this paper, 4 recommendations, is an update really just in terms of where we are with this, the resource ask, and the hub process that we're out to procurement on.
Richard, thank you very much. Any questions for Richard? Steve?
A mundane question. £383,000, is it in the budget?
Yes, so okay. I'm sure Chris can confirm, but we do have a funding pot that we went through both the SNE Directors of Finance Group and we got sign off through our exec management team, hopefully endorsing here today.
Okay. Chris is busily nodding here. Did you want to add anything, Chris? Or?
No, it was just something that was on the long list as part of planning that we went through a long process through internally in terms of what would the priorities be. And this was on there, so there's the budget available to support. Yeah.
Okay, thank you very much. And Ed?
Yeah, I'm very supportive. This is a great engine for collaboration as a system, isn't it? And bringing us all together, literally onto the same page. Just wanted to reference the programme director, Alex Royan. So he was working at number 10 Downing Street, then went on to bigger and greater things working for ESNEFT, for Nick, and now has reached the pinnacle working for the ICB. But he's incredibly talented and is, you know, someone that's going to really drive this forward very well.
Thanks for the prompt, Ed. I should say that a massive thank you to Alex, who's reached the pinnacle now working for me on this piece of work. He's fantastic, Nick, so thank you for lending him to us. And on a serious note, we are ahead of the game. I know we like to be ahead of the game on this, comparably to many of our other ICS, neighbouring ICSs. And we are part of another regional group that's looking at this, and we're being asked to speak more broadly nationally on the work that we started off on this. So it's good news, hopefully.
Okay, thank you very much. So with those sentiments, are we happy to take all 4 recommendations en bloc and approve, or shall we go through them one at a time? Everybody happy en bloc? I don't see anybody dissenting. Shall we say approved? Excellent. Thank you very much.
Thank you.
Thank you very much, Richard. Now, item 12, the Cassius presentation, we're not going to have today because of an apology in presentational terms. So we're going to carry that forward to the next meeting. That then takes us into the third section, finance, performance and strategy, with item 13. But before I go to Paul, let me just look around the table. If you're prompt, we are 10 minutes behind, but if we're prompt thereafter, do you want a 5-minute break, stretch your legs and do the necessary? Ed? Yeah.
So it's just on the Cassius item, so it's a shame it's been postponed, but I understand the reasons why.
Mm-hmm.
But what I would have said if that paper had come is we should look at extending that model, if we can do, into the NHS context as well as into the system, because there's so many benefits that are coming through the Suffolk County Council approach that we need to look at. So we're just keen that whichever group it is within our governance starts looking at that question, so that we don't waste time, because we've got an operational crisis and we need to take every trick, don't we?
Yes, good point. And perhaps we should specifically ask for that to be covered at the next meeting when in the presentation. Yes, Peter?
I wonder about doing a joint paper, because Essex also launched a care tech service in July of 21, and it'd be interesting to get learnings from each one and where we can take it next.
Brilliant. Sounds good. We might need to allocate it a little bit more time as well then in that case, as Ed has said, a very, very important issue or matter. All agreed? Okay, in which case 5-minute break. So, okay, 6 minutes if you're quick. Back at 25 to 4, yeah? Thank you very much, everybody. Right, let's crack on. Thank you very much. And we are into finance, performance and scrutiny. Item 13, the oversight framework. Paul, all yours.
Thank you, Chair. Before I start, I suspect there'll be quite a lot of synergy in terms of the system intelligence function and what I'm about to talk about. But essentially, the focus of this paper is really to instruct, inform, appraise the board of the general direction of travel in respect of how our regulators are likely to be assessing us as an organisation. And there is still a high degree of uncertainty how that's going to work, and hopefully I'll talk you through some of the details of that. So just to start, it's absolutely evident, and it's part of our constitution, that our regulator will assess us on a yearly basis. And in order to do that, we were essentially directed to set up a system oversight and assurance committee, which is essentially an interface between NHS England and ourselves. And to that effect, the committee is jointly chaired by NHS England and ourselves as we move forward. Technically, the SOAC had its first official meeting on the 6th of September, but has been meeting a few times in preparation to that, and I'll talk a little bit about where it's got to in its current thinking. Fundamentally, though, the SOAC itself is underpinned by a memorandum of understanding, which clearly sets out how NHS England and ourselves are going to interface and work collectively on addressing some of the issues. And it's key to state that it is a progressive level of individual ICB accountability. So again, Nick mentioned earlier on, operational framework are likely to change. There is a very clear direction of travel. The ICB needs to be self-sufficient, or it's self-accountable in terms of performance and outcomes moving forward. So we will see an increasing element of that moving forward. So to cut a long story short, SOAC has essentially the ability to request deep dives, request plans, escalate to board any particular issues of concern, make recommendations around different advice on investment, given the various priority, and make recommendations. So in its first very few meetings, we've been road testing a number of the things. So we've reviewed winter plans, urgent care, we've reviewed cancer services, maternity services, and deep dive across mental health, particularly sub-4 and SFT, current CQC positions. So we've done quite a lot of conversation at system level to start to understand and test really how we might start to work as a SOAC committee. So I think putting my crystal ball on slightly, the $64 million question is, when our regulator looks at us in 6 months' time, 3 months' time, how will they start to assess us whether we're a performance ICB or not? And I'll prefer a number of views on that. The first one is sits around the SOP framework, system oversight framework. And it's part of the paper, but I won't go into the detail of it, but it looks at it through 6 prisms: leadership, workforce, finances, and KPI outcomes. And on the back of the system oversight framework, there are essentially 60 KPIs. And what it does is start to segment those KPIs into the various domains. So that's the first point, and I'll come back to those in a minute when we talk about data and where we've got to with that. The second component that they are likely to look at is through the operational delivery plans for this year. So again, we've been set some ambitions around elective recovery, urgent care, maternity services, cancer, mental health. Okay, so they will look to see how well we performed against those operational plans moving forward. And in fact, I think our next meeting, our regulators, are around the 7th of November from memory. So one of those meetings is fast approaching. There's clearly the constitutional targets, and those have not gone away. But clearly, as we are in recovery, we end up in a position where we have differential outcomes. So we want to see 18 weeks, 95% RTT, but actually we are at 68%. It's our journey to get back to our constitutional target, which is the important conversation, which is why the operational framework leads us into that direction, and we'll see some greater ambition as we move forwards. Some of the things we've sort of started to hear about today is it will start to look what our local priorities are. So we've talked about population health management, for example. We will need to set our own local ambitions, what we want to achieve as an ICB. And again, I don't think we should necessarily be limited by those KPIs that have come up from health. Actually, we can set our own direction of travel as an ICB in terms of what our expectations, our ambitions are in terms of population health management and how we measure things. So increasingly that element will feature through the SOAC conversation. And I think, as Richard has stated earlier on, we've anchored some of that work into SOAC, which is why there's some synergy, and I think it makes sense to start doing that. We also need to be mindful, and Lisa will be able to talk about this far more than I can, but CQC are also looking how they're going to assess ICBs going forward and are developing a framework to do that. Now, it won't probably do it in the same way that it does our main providers, because it will not have if you want, an ability to direct us, but it will influence the way our regulators look at us in terms of how well we are performing as an ICB. And finally, there's a whole conversation about system maturity. Have we delivered the things we said we would deliver in terms of establishing our governance structures, how we work collectively, how we move things forward? So it's very likely that our regulator will look at it through all those lenses, but it is unclear how they're actually going to do it in practice. So there is a level of uncertainty, but we can start to predict maybe how they're going to start approaching it as a step forward. The second bit for me, and it was really, really important that we didn't start to create an absolute industry around performance and assurance. So you will see that our governance structure and our performance structure mirror each other. So within the document, you will see the governance structure, and there is an expectation through delegated accountability to those committees, they are equally accountable for that performance element, as well as transformation, as well in driving change, as well as reviewing, a variety of priorities. And it is those committees, so a set of SROs that feed back in SOAC. So that, if you want, is the how bit. At our last meeting on the 6th of September, as I said, we reviewed a number of things, and I'll come back to 2-3 things specifically in a second. But it decided not to escalate at this point to the ICB. I suspect it's early days at the moment, and we are still finding our feet in terms of the conversation we need to have. But I would press a couple of things. Probably the best way to summarize the last meeting was we really focused on probably 3 key things. Our search plan and our winter preparedness, which is really key and important, given the fact that we are likely to face a very difficult period of time. And so we were assured that we would go all the plans and we were, sort of developing those appropriately. There is another element around essentially urgent care framework, which we have submitted yesterday back to the regional team, which is going up to the national team today, which is actually a test of best practice across the system. So we talked about that process and how that might influence our work programme moving forward. And finally, Ed talked about our ambulance conveyancing standards, and we started a conversation with the East to start to understand what the recovery plan might start to look like. Slightly difficult position in the sense that they've not yet published their recovery plan formally, so difficult to talk here in details, but we are having that conversation at SOAG in terms of what does your recovery plan look like, how can we support that recovery plan, how can we make sure that that population get the best response possible. So again, just a bit of a flavour in terms of the conversation we are currently having. The whole purpose of that assessment is essentially where probably I should have started, which is to say, as an ICB, we are placed into a segment, and segment goes from 1 to 4. Segment 2, which is where we were placed in November, is you're doing well as an organisation, you've got a little bit more mature, a little bit more work to do, but you're not triggering a sub-3 position, which would attract a level of integrated support package into the system and not where we want to be. So default position segment 2, segment 3 and 4, you have to actively fall into that in terms of in terms of your performance. Segment 1 is an aspirational, and actually we would strive and have the ambition to be in segment 1. And I would suggest that it is the purpose of this ICB to make sure we have that ambition. My understanding is there is probably only one ICB nationally that have landed into segment 1, and that was Frimley. And my understanding, we marginally just missed on segment 1 as a system, because we are considered as a fairly high performing system generally. So again, segmentation is usually important and would be the marker of how we looked at moving forward. So finally, just a few other bits around the data. We took a bit of an ambitious step in so much that we didn't throw away all the data that we had, but we realised very quickly that we had to think about data very, very differently. And if you look at the current construct, or the current as was of the BI team, they were very focused on what I call bin counting, Excel spreadsheets, rather than the intelligent element of what we were trying to do. And it was really important that we start to think about moving to automated intelligent reporting of data. So Power BI, and for those of you who are not sure, it's essentially an immersive visual data which you can manipulate. You can delve behind that data and look at the intelligence that sits behind the data at the click of a button, essentially. So the teams have been working really hard to start developing dashboard that allows to do that on a real time and look back basis. The other element which was really important is we don't often marry the data and the local intelligence. So through Power BI, we are now able for each of the committees to populate the narrative intelligence that matches the data performance. So what did you do last month? What are you doing this month? What impact is that having this month? And actually, what are your difficulties? What are your risk areas? And what do you need support with? It's very much the framework we are trying to develop on that basis. The other very key important thing for me, and we've had a conversation with the national team around making data count, which is around SPC, which is essentially statistical process control, which essentially helps us to start looking at that very differently. And you'll notice within the data there are a number of icons starting to appear. One set of icons saying it's getting worse, one set of icons saying it's getting better, and this is where you need to be focused on. And one set of icon that says it's either getting better or worse. It's what's called spuddling. And actually, maybe we might choose to look at those. So it helps us to draw our eyes to where we need to be looking at in terms of the data and in terms of performance. Because otherwise, you'd end up talking about millions of data and actually not focusing maybe where you need to be. Some of that data, you'll notice, requires some setting of ambitions. So it's new sort of data. We've not had the committee conversation to say what do we set our benchmark as. Some of the data hasn't had enough runs to have SPC charts, and that we'll translate as we move forward. And again, then there is a very big area, which is why I was very keen for the BI team to be freed up to supporting the committee to start developing local intelligence, local data that doesn't just reflect the soft KPIs, but much more than that in terms of the conversation we had around intelligence, for example. And we are developing training packages and work with the various committees. And from memory, our priorities are going to be probably quality, because that's one of the most complex ones. Alliances, because partnership is absolutely key, and mental health, because we know mental health is really challenged. So at the first out of 10, those are the committees we are focusing on in terms of support. So getting to the data, and again, maybe there is an element of conversation with this board. In some respect, is what level of data do you want to see as a board? What level of conversation do you want as a board? Is a really key question for me. So I'll pick sort of three that I'm intimately involved in to some degree or other, and give you a bit of a food for thought before we get into my final bits. So cancer, we remain one of the top performers in the region. Around 60 to 31 days, but we know we've got a challenge because our 62 days are a long way to our going. Okay, so there is clearly an issue for the cancer committee to address, and they are working on that. Elective activity has been a massive challenge, and as Ed has already alluded, fourth best performance nationally on Q1 as a system, best performer in terms of SNE. Comparison can limit ambition, I would suggest, and actually we need to actually be thinking about recovering fully. But it does give us an indication where we are in terms of the systems. And what we've also seen is a growing partnership working around mutual aid. We've seen significant reduction in inequity of access, which was quite significant as we started through the pandemic. So, and we are achieving 104 weeks reduction. We are achieving 78 weeks, but we are seeing our 52 weeks and above rising, because we fundamentally have a capacity issue, which is something we need to address moving forward. And I've talked about UEC, and we do really quite well on our ambulance delays, but we need to be more ambitious. We have top performance in our 7, 41, 21 days length of stay. But again, we have a group of patients that still remain in our beds that we're not moving quickly enough, which is causing some flow issues. So that gives you a bit of a flavour of some of the data that is available. And you'll see within the report a dashboard which marries to each committee with the data, which is the soft data, and a bit more data with the relevant narrative, which is discussed at SOAC. So essentially, in terms of the ask of this board, I think it was more to note the progress that we've made to date. I think it's to acknowledge to some degree the work that's been currently ongoing as we move forward and develop, if you want, our performance framework further, and really to endorse the next steps, which are sort of in not detailed, quite detailed, but the next step around supporting our committees to develop their information function and performance function as we move forward. So I'll stop there. It's a quick whistle tour of the paper, which is both, I think, quite complex and simple in equal measures.
Paul, thank you very, very much. And I'll go to Ed first and then Nick. And Ed, you might also choose to comment, if you want, on Paul's challenge around whether we have the ambition to be SOF 1 or not, something you and I talked about only the other day.
I think you put that in my objectives, Will,
yeah.
so I'm not going to depart from that.
I was on safe
2 days
territory.
later. Thank you, Paul. A couple of points from me. On the data we look at, so we talked about Power BI, but in my experience, NHS England have 6 or 8 metrics that they look at every system on, and if you're not delivering on those, you're not seen to be performing. So really key that the board see those metrics. And then thinking about what Susanna was saying earlier is what's important to the population in SNE, what are the things that they want to see us turn the corner on to. So I think if we have those 2 thoughts in mind, as well as all the plethora of data that will be coming through. The second point is, and we'll work this out, but I'm not clear on what's the conversation we have at this board. So we've got, with urgent care, so we've got an urgent care committee, we've got lots of conversations in the alliances, we've got the SOAC, which brings it all together, but we also need a conversation at board without letting it dominate the whole agenda. So we just need to think about the balance, because what we can't say is all the conversations are happening over there, we're not going to talk about it at the board. So I know that's not what you're saying, but I just don't want us to fall into that scenario. So we'll work it out with experience and progress. We'll get there, but it's just let's get the right balance.
Yeah, as long as it's brief, Paul. Yeah.
This is why I think segmentation is so important. It's about the lens through which we look at performance, and to some degree, because that's how we're going to be judged from a regulator's element of that. But my point is that we need to be far more ambitious than that in terms of our system, and that we will choose to pick certain performance elements or outcomes that we want to see happening. So absolutely.
I agree with it, but Cetra states that ambulance handover delays is the first thing on her list. If we're not delivering on that, then that's a big problem. So it's just looking at it from all angles.
Yeah, good. Thank you. Let me go to Nick and then Steve and Stuart. So.
Thank you. I mean, this is really tricky, isn't it? Because I remember the first STP meeting we had. When God was a boy, it feels like a long time ago. Somebody made the comment that partnership works at the speed of trust, and I've never forgotten that. And it's actually a quote from somewhere else, but it's slightly changed. I think the question, and we have this at every board, don't we? Whatever board we're part of. At what point do we trust the process of those people delivering? Because the one thing that will lead to failure is for any SOAG committee or anybody else to spend hours and hours and hours asking the same question that in any organisation has been asked 8 times. So a detailed analysis of ambulance delays on any of the acute sites is a waste of everybody's time unless you believe we haven't done that. So I suppose it will affect the relationships because it's just not going to be seen as valuable. For me, it's about the performance report that then feed into the board or the committees that identify those issues that are filtering up from providers, that identify whether that's primary, whether that's secondary, whether that's tertiary, whatever the issue is, that identify the issues that can only be solved through partnership. Because with the greatest respect to my colleagues in the room, there are lots of experts to move ambulances off forecourts in acute hospitals. It's kind of what we do. What we can't do is fix some of the system problems that result in that. So I think the whole performance piece, so it's how do those issues bubble up that only we can only solve together. I think your point about we have to create enough space to have the license to do the stuff that matters to the people that we serve. And the way that we do that is to keep regulators off our back. And the way, the way that we might perceive that as providers is to keep the ICB off our back. That's unhelpful. So I think that there is a piece there, because we know that the vast majority of healthcare happening in this city now and across the country happens in primary care. When you look at the proportion of KPIs in primary care compared with the proportion of KPIs in every other aspect of health delivery, it's in no way proportionate. Is that right? I don't know if it's right or it's wrong, but it seems weird, doesn't it? That where the activity really happens, we pay the least attention. Where less activity happens, we have hours and hours and hours of attention. We have decisions to make about whether that feels appropriate for the local people that we serve. So I think create the headspace to give us the license to do the stuff that really matters, but not to spend a huge amount of time looking at our balance sheet, because kind of I've got Adrian is pretty good at that stuff. So that will develop, and that assurance and that trust piece will take time. But we need to get to the place where, as a board, we feel confident that the people who are not sitting around this table are doing the best of their ability, and that we deal with the issues that are so the point I've been making a lot nationally recently is let the people who are delivering care deal with the performance, and let the ICBs deal with the problems, and to differentiate those two. But recognising you've still got to sit in front of the region and the national team to justify your existence.
Okay.
Really well said.
Yeah, thank you for that, Nick. So focus on the right thing in the right way at the right time. I'll come back.
No, I just want to, I know you weren't being critical, but I just want to say that,
Go on, Frida.
that I just want to make a little tiny point, is that when you do look at KPIs being fewer in primary care, yet we have the greatest amount of contact, the least investment is in primary care. It correlates with that.
Maybe because you've got those KPIs, the driver of investment may
Well,
be
possibly.
the speculative state wakes up tomorrow.
Yeah.
Goes, I think the key to that is GP practices is the excellence.
And let's hope she does.
Okay. So what we've got to, as a board today, of course, we've also got to be careful that we don't spend too much time violently agreeing with each other as well. So let's keep moving. Let me go to Steve and then Stuart.
Well, I was going to say something, but supportive of Ed's comments. We've got to have something that comes to. There's got to be some mechanism that we get in front of this board, the top end of the indicators. Don't want to get into all the. I don't want to look at your balance sheet. The last thing I want to look at. Thanks very much, Nick. And I absolutely buy into what you're saying about the experts in delivering stuff and making things different and better are actually in the front end. Whatever the provider end is called, that's where people are who know how to do the stuff. So the more we can empower them to get on and fix, the better. But, I don't like buts, but you've got to have one. But we do get over, somebody looks over our shoulder. And we've got to make sure that when they look over our shoulder, we're doing enough of the things that matter to them that they say, tick VG, we're off.
So it's balance again.
And at the same time, build in those things that we think really matter to us and our population. You might put that the other way around, I don't mind, but those are things that our regulator hopefully will be impressed that we're attending to, but they might not care one iota whether we do or we don't. But that's what we've got to try and focus on, and I'm anxious to understand quite how we make that happen here without us getting a copy of the 61 KPIs plus the other 47 the Secretary of State invented last week, plus the because I know it's not 61 when you start them up. I've seen it before. You've probably got a list of 237, because that's what the number was when I was a boy, and it probably still is 237. So we've got to find a way of making that happen. And I wonder, is that our SOAC? Is that where we expect all that to be brought together, and a summation of what's important finds its way to us, or is it something else?
Let me go to Paul.
If I can come back to the way we've started to build this up has been deliberately in that way. So what you've actually got in the document, if you want, is a dashboard with a narrative. the way I'm thinking about it is for SOAC to analyse, look at it, bring the intelligence forward, the recommendations of what the machination of the conversation that have come out. But of course, I think all the data should be freely available to any board members to look at it, should they wish to look at it. And the reason why Power BI is so important is that it is available online for all to see and to look at it should they wish to integrate the system.
Absolutely. The more visibility it has, the more people, the more reliable it becomes. Yes, that's the idea. The more reliable it is because more people ask sensible questions and then it gets all right.
And I think what Ed was getting to is that because some of the national pressure and some of the key metrics, there is no reason why that can't be as a summary be attached to an appendix to say this is where we are as information. But I suppose my vision, my thoughts are that you've got a summary paper from the SOAC outputs into the board.
Yeah, that would be good. And I think in terms of performance indicators and evidence in software.
I'm glad Steve supports that. Let me go Stuart and then Peter. Stuart.
Maybe this links to Ed's point about what's important to local people, but I think we obviously have this list of indicators, and whichever length of it is, 200 and something or even further. I think for me is about, as we develop our local intelligence functions and build on them, it is about how we also view that. So we could just look at those normal global indicators, but actually what does it mean for different parts of our population? And I think there is an inequalities lens that we need to put on there, because we can still be tapping ourselves on the back saying we've now met that benchmark, but actually we might not be meeting it for all the population. So if you want to put some effort and resource in, you've got to do what you need to do for your regulators, but I think we need to be challenging ourselves particularly about what it means for different parts of the population, because we may not be achieving it for everybody.
Thank you, Stuart. Well said. And Peter?
So really brief, because he's nicked my points. Exactly. There's no point in us improving diagnosis and treatment if we're not improving it for the worst affected outcomes in communities. And totally agree, whether we're having to track 100, 200, 300 indicators, we need to know what are the 10, 20 that we really care about and want to move the dial on.
Yep. Thank you, Susanna.
So, I mean, it's just worth saying that as we work through both our integrated care strategy and also the process around planning, joint forward plan, and obviously planning through other parts of the system as well, this issue about measurement is really important. We've agreed through our strategy to kind of weave measurement through. We've agreed to base that on the things that people tell us are most important to them. There's a difference between impact in terms of population outcomes, people's experiences, and also impact on equalities, which we're kind of teasing apart at the moment throughout the process. There's a difference between population accountability and performance accountability. So it might be that once we've kind of got a bit further into that and kind of shaken out all of the things that we possibly can measure, and some of the things that at the moment we're blind to and we don't necessarily measure, that we bring that back. But by far, and I'm just thinking back about the experiences we've had as an STP and then an ICS, and obviously I just left school when the STP started, that what was most important, I think, was the fact that data was shared and it was available and it was visible, and the fact that we shared data so openly as the system built trust, and you know, that is just really important. So maybe if we just start sharing that information, it will start to kind of bring forth kind of, you know, some attention on some of the things that are really important. So thank you, Paul.
Okay. So we are, as a board, asked to receive, note and endorse the next steps and developments. I think we're saying that yes to all those recommendations, but that also that we recognise the challenge of getting this right, and that this is a journey that we are on, and that getting balance right in many senses, actually, many different balancing points, is something that we've got to work hard on. And it'll work better if we learn to and behave in a trustworthy way, where we're trusting of each other with openness and transparency. And our ambition is to be SOF 1. Is that all agreed? Paul, when are we going to receive the outcome, the next steps? What's the plan from a board point of view?
So there's a couple of things. You'll see within the report there is a next step bit on the BI team and Can you put your mic on? Apologies. A bit of a let's manage expectation bit, because actually this is an awful lot of work. So there is clearly a process within that. But certainly we can start to report the output of SWAC pretty quickly, because we have been running in that way anyway. One thing that I tested last SWAC was to say, is there anything you want to escalate? The answer was no, following a large conversation. But I'll construct it in such a way that actually it feeds off, if you want, the overall report and bring it to the next board.
Next board. Okay, that's great. Thanks. Everybody content? This is a challenge, isn't it? But we're embracing it and we're going to beat it. I'm going to then move us on to the next item, which actually is so some similarities maybe here, Amanda. Board Assurance Framework. Over to you.
Indeed, thank you very much, Chair. So, this is our current Board Assurance Framework for September, and as we can see, we currently have something like 23 key strategic risks. Now, what I think is important to note is the design is very much work in progress, and as discussed at the Audit Committee yesterday, we need to, I think, get better at the design of the framework, be better at what the risk is and what the mitigation is and the timeline. So all of that work is actually happening at the moment, and we actually are committed to going back to the Audit Committee, I think it's December, Steve, from memory, where we are aiming to present a revamped version of our BAF that hopefully will be acceptable and meaningful and the like, which in then turn will come to our board meeting in January. So that's very much work in progress. But I think in terms of managing our 23 or maybe less risks going forward, there is greater grit, I think, that we can play in terms of making sure the risks are managed appropriately. And I know this is something very dear to the Executive Committee, in that they are committed to actually spending considerable time each month to go through each of the risks, make sure they are the right risk with the right leadership, with the right feed through to the various committees. So ultimately the Audit Committee can be assured around process and the like. And then we as a board can be assured that we have the management in place and that we have got the totality of the risks for our system that we are actively managing. There may be other risks that we need to actually add as we move forward. But the point I wanted to also make is, supporting this overarching BAF, we have a number of risk registers that have directorate-specific risks, if you like, which are reviewed monthly by the Risk Forum. And those risks we keep a watching eye on, because they may actually escalate to our board assurance going forward. So that's something that I wanted to share with the board this afternoon. I don't know whether any of the risk owners wanted to amplify any current risks, but I think the point that I would want to underscore is each director is currently with the relevant committee, making sure they are the right risk, we have the right mitigation, and we have plans moving forward to actually proactively manage and the like. I'll leave it there, Chair, but very happy to take questions.
Thank you very much, Amanda. Steve, Ed, and then Nick.
If I come in, as Amanda said, the Audit Committee met yesterday and had a conversation about this, and the BAF was presented as a work in progress. As a staging post. There are a number of important things that we were anxious were kind of taken forward in the review. One was the structural stuff that Amanda's mentioned, who owns it, when's it going to be, what's going to be done about it, what the mitigations, all that sort of stuff that needs to be kind of better reflected. There was a sense in which there were some risks that maybe hadn't been fully, there were risks emerging that needed more exposure in the risk register, things that have been coming up in committees at various points that are not yet fed through, and those need to be picked up. And so allied to that was how can we take what has been a register, or a process I should say, that's been structured, we inherited from CCGs, in turn inherited from PCTs, and probably adapted from a health authority in whatever year it was. But anyway, certainly the PCTs and CCG bit has been a kind of how do we adjust this process to reflect the fact that we're now thinking about the world in a somewhat different way, and a system approach. How does our framework acknowledge that we operate in a system, acknowledge the capabilities and independence of various of our partners to do their thing in their own place, and then somehow, it's a bit like the performance thing that Nick was referring to earlier on. What do we bring up into this risk kind of conversation we might have here, which is system, not a repeat of something that's been handled by another of our one of our component entities, if I put it that way.
So same issues really, or similar issues?
Similar kind of issues,
yeah.
but that's the conversation we had yesterday, just to reassure the board that that's getting kind of some attention. And 15th of December is the date when we're planning to see a kind of reflect. Sorry, Steve, yeah.
I just wanted to add to that there was about the ownership. We had quite an interesting discussion. I don't know, Nick, how you run your trust, for instance, but when I've been working, whenever I've been an exec, I've had my name against the board assurance framework domains that I'm responsible for, and there's been a platform that sends me an email saying it is due for review and you have to update it. So it struck me there's something we can do to automate the system.
Yeah.
But the other discussion we had, which I think is really important, which is, say, workforce, or say travellers and migrants, and think there's some collective things, isn't there, out there, that what's the equivalent at the ICP level? Because in a sense, there needs to be a mirror of the board assurance framework for the ICP that is saying these are system level risks that are going to be solved in a different type of way, that otherwise we'll just keep on building in ownership at the ICB, and that won't help you, I think, in the longer term.
Okay, thank you, Steve. Ed, and then Nick.
Yeah, I was just building on Steve Clark's point. So the wording, the narrative around these risks are developed through ICB executives, but some of this is kind of organisational specific. So risk 4 around maternity at Esneft. What's the ownership of that? Should that be Lisa and Nick, as Nick's around the table? It feels a bit odd if it's not a kind of collaboratively owned risk.
Yeah, and in that sense, Ed, you're also sending the sentiment of not walking away from any risks there. Yeah. Mm-hmm.
No, but the idea is we're all in the room together, rather than a commissioner-provider split.
Yeah. Thank you. Nick.
I mean, really very similar comments. Very similar comments to what I said. I was looking particularly at the cancer risk. And it's interesting that the cancer risk strategically is failing the constitutional standard required by the Department of Health. I get that, but actually missing 62 days increases mortality in colorectal, urology, breast, and head and neck, and we know that. Now it's in there, and actually the cancer risk for the system is late diagnosis. It trumps any of this. 62 days, 31 days, 2 weeks, whatever. Late diagnosis is the biggest risk, and why we've got one of the worst outcomes in Europe. Should declare interest. I chair the Cancer Alliance for the region. But surely that's the risk to the ICB, to the ICP, and to our population. The risk of failing constitutional standards probably sits with the organisations, but it comes back to the bit that we will be held to account as the Board for Constitutional Standards. So it's all the same. I think it's a really, really rich discussion, and I think it's the beginning of and I'm just wondering how, as a board, we could take some time out, more sort of seminar style rather than board meetings, to really, whether it's performance, whether it's the BAF, because the BAF drives the performance. So I think it's a really good conversation, but the risk to our population is late diagnosis.
That's a really good point, and I saw a lot of nods around the table, Nick, to almost everything you said there. But should we specifically take the suggestion of a time-out discussion into a development session on this and the wider issues? Everybody happy with that? Yeah, and maybe that might be sooner rather than later, mightn't it? Actually, so let's note that. Any other questions, Susanna?
I think sooner than later would be a good idea, because I think this is very relevant to the conversation, to go back to the point about measurement and the issue about where are the specific risks for our population, and how we're responding to those and so on. So we do need to wrap that into the kind of conversations about strategy, and it goes back to the debate which we're right in the middle of at the moment about how do we set priorities and how do we collectively manage kind of risks, if you like, that that people living in Suffolk and North East Essex are facing. Not if that's a bit different to organisations. So
yeah,
that would be good.
Okay, thank you very much. So as a board, are we happy today to thank all the team that have done the work on this thus far, and there's a lot of people involved, obviously. Particularly thank Audit for the work so far. Recognise that it's a work in progress, that we approve it today as a work in progress, not a finished product, and that we look forward, actually this is going to come to the next board and in November and then again in January post your, did you say December meeting, yes, Steve? December. Yeah. So we look forward to future iterations and development.
Don't forget the kind of seminar kind of
and absolutely in development, yeah.
That's really important development.
Yeah.
And
And let's see if we can get that into October or November, but we'll work on that, yeah. Okay, thank you very much, everybody, in which case then let's go back to Paul for procurement. And Paul,
I'll be brief.
Yeah, you need to be brief for me, thank you.
Yeah, so I'll take the paper as read in that case and just pull out probably three things. The paper sort of showcases the amount of work that's been done to unify two systems together. So you've got a whole list of things that we've done and continue to do that to make sure there is one procurement approach across the ICP as opposed to two. The second bit of the conversation within the paper is we are trying to realign commissioning, finances, procurement and all those elements, because we have been through a very interesting time through the pandemic where a lot of the book tended to be thrown out the window because we need to move really, really quickly. And there is an opportunity to really start to think about how we systematically make sure we follow all the right rules and line everything up as we should. The third bit of the conversation within the paper is really what do you want to see at this board. So at the moment it's being proposed that for you'd receive financial reviews, procurement reviews, what's in the pipeline, any changes to provide a selection regime, for example, which is up and coming. So essentially it's whether this gets reported here or whether it gets reported maybe to an audit committee, for example. And all the only thing that comes here is when there are decisions and sanctioning of awards, should we say, around procurement. So essentially that's what the paper is asking.
That's great. Any questions for Paul? Otherwise, we're asked to receive, note, acknowledge, and then agree, if we're so minded, the proposed reporting structure. Everybody content? Marvellous. Agreed. Thank you very much. Let's then move on into our final section, governance and corporate business. The next paper is Lisa on the confirmation of key executive lead roles. Over to you, Lisa.
Thank you. So as the paper states in 1.1, each ICB is required to identify executive members with explicit responsibility for 5 particular population groups and functions, and these are the first 5. We are expecting more to come from NHS England. So the 2.1 details the 5 areas: children and young people services, children and young people with SEND, safeguarding, learning disability and autism, and Down syndrome. And they've all, apart from Down syndrome, been responsibilities that were previously assigned to executive directors within CCGs. So we have taken a bit of a pragmatic approach and just continued that responsibility allocation. So it details some of the functions, but again we are expecting to get more information from NHSEI in time. But we are asking the board to note that the executive lead for Children and Young People Services will be Richard as the Director of Strategy and Transformation. He was previously doing it in the CCG, so it makes
makes sense for Richard to continue it. I will retain the exec lead for SEND. I will retain the exec lead for safeguarding, both children and adults. Exec lead for learning disability and autism is currently myself, and it makes sense to link the new responsibility around executive lead for Down syndrome to that portfolio as well. So obviously this is just the SROs for it. There'll be a very much system approach to it, to all of those portfolios, and we are expecting some more statutory guidance later this year which will set out the performance of the roles. So I'm just asking you to note the paper.
Thank you, Lisa. Steve?
I'm perfectly content with the proposition that's there in terms of who gets the sort of lead roles. Hard luck this you got for most of them. I guess the only thing, it's a recurring theme of today. My understanding is that most of these are there are named individuals required in every one of our provider trusts. That operate within the system, and there might be others besides that I'm not aware of. We need to find a way of making sure that we build on that, not replicate, because we've got the capable people out there that you can rely upon.
So I think we already have really good processes for doing that. So for example, Richard will say for children and young people, he's joint SRO with Alan Cadzow from Suffolk County Council, and similar with Chris Martin in Essex County Council. For learning disability and autism, it's very much a system group. Georgia Chimbani chairs the LDNA Suffolk. She's our Suffolk County Council lead. So we already work with the system partners really closely. It's just the ICB executive having named people. Thank you.
Yeah. Happy with that, Steve? Good. Any other questions for Lisa? Otherwise, noted? Wonderful, noted. Thank you very much. So then on to the next item, item 17, board capacity and diversity, Amanda. And this was requested by this board in our first meeting on the 1st of July. So here we are. Yeah, and Fanwell, please do join us.
Thank you very much, Chair. So indeed, it was something that the board requested in July. It very much is work in progress, but we did commit then that wherever we'd got to, we would present an interim update today, which is what this paper addresses. And I think in terms of summarising the paper, it's broadly in three components. One, around our broader ambition on the totality around EDI and the agenda and our board vision and strategy and the like, which I'll come back to. Then there is something around our current NEM capacity and how we may want to strengthen that going forward. And linked to that is then the wider succession planning of all of our roles around the board table. So if I take each of those points in turn, and then I'll invite Fanwell to come in as well. In terms of our broader ambition around ED&I think we would all agree it's vast. Okay, and when I was at a meeting the other week with regional colleagues, Region are now offering each ICB board to actually do further development work on the EDI agenda. And their offer is to come out and meet us, perhaps at a board development session, and really get into the detail on where we currently are, where we would like to get to on ED&I, and how they could support us in our journey. So that's an offer that we may wish to accept or otherwise. And then linked to that is then the current issues around NEM capacity as we move forward. And we discussed briefly in July, and this paper identifies where we currently are compared to where we are with other ICBs within the system and beyond. And I think it's fair to say that we are not necessarily an outlier within the region, but potentially we are if we look beyond our east of England. So there is opportunity, I think, to take stock of that so that we can progress going forward. And then linked to that is that wider succession around building the capacity and capability for tomorrow. And one of the suggestions that clearly we can work up, if indeed that's something accepted by the board, is to look at how we may create associate non-executive members going forward, again as part of developmental and as part of our succession. So opportunity and talking with other colleagues, I think it's something that other systems are currently considering at the moment. And that might be something that we actually think, yep, that's a good idea, just need a bit more thought on that. I'm going to pause there and invite Fano. Do you want to add anything to what I've just said? Thank you.
Thank you, Amanda, and thank you, for inviting me here to talk about this issue, which I think some of you know it's something that we've been pushing for, for quite a long time. Some of this sort of builds on some great work that we've done, from the What Are We Missing program during the COVID pandemic, which I think our communities are recognizing as some very good work, where we did sort of stepped outside of the box and said, what are our communities saying? What do we need? And we listened as a system. And I think building on some of the work that Susanna has done as well around thinking differently together and sort of whilst I in this paper we're talking about the fact that we're not an outlier, but I think one of the things that we have done is taking leadership in some of these issues. And I'm not going to go into the kind of why it's important to have diversity on the board. I think everybody knows that. I think the bit that we are looking at in this paper is the what and the how. So how do we actually go about doing this? And part of the proposal, which I think Amanda, you're going to talk about, is really a piece of work that needs to happen, post this, should the board approve this paper, is, we need to take everyone on a journey. We need to take our communities on this journey, but we also need to take the board on that journey, because the most important thing, which, I sit on various committees and everyone is talking about the ED&I agenda, but people will look at this board for leadership and they want to see what is happening in this space, which they then want to build on. So I think it's really important that not only are we saying the right things here, but we're also doing the right things, and we reflect the communities within which we operate. And I think it's very important again that whatever we do here is not tokenistic. It has to be something that actually drives the outcomes for the people that we are working with, and the way you do that is, some of the proposals around how do we build those people who can come and be part of this and inform the work that we do. And I think there are some, very good proposals and ideas that we want to work on, moving forwards to build that capacity on the board.
Okay, thank you very much. Let me go Peter, Steve, and then Frida.
Thank you, and a really good update and a really important agenda. Just wanted to share something we've been proud of, actually, that we've done in Essex over the last year, particularly in adult social cares. We've developed the idea of something called a quest, and that's where we've released some of our staff members to pursue a quest. So we've done a quest on race, we've done a quest on disability, and we've actively gone out. The quests have been developed from people from ethnic minorities or those with disabilities, and they've told us what is their experience of working within a system or within the organisation. They've looked at data, and they've given us a series of recommendations. It's a new innovative thing we've done. I'm sure the team would be delighted to speak to you to see if you wanted to learn from that or do anything similar.
That sounds like a great idea. Thank you for that offer, and Amanda and Funwell, I'm sure you'll take that up. So, Steve?
Yeah, I guess I've sort of said this before. I think there's something really important about the diversity of lived experience to me. We could easily appoint someone who has a university level degree in law that represents all 7 of these, whatever it is, characteristics, but not actually have any different view at the board. And it strikes me that we are looking into some geographies where there are people. I mean, Victor Adeboale is a good friend of mine, and there's a guy that started off working in, frontline services and has kind of worked his way through, run a company. Let's please keep that richness of experience at the forefront. And then I think these other characteristics, if we're open-minded enough, will fall into that without us having necessarily to do it the other way around.
Yeah, good point, well made. Let me go Frida and then Susanna.
Yeah, I just want to say that I'd really welcome a board development on EDI. I think that's really, really a good idea, and I think you and I have spoken about that as well. But also the associate NED role is interesting. Whilst I think it's a really good way, and I think if there's an attached training programme, which I understand there will be to it, which will be important in developing NED role, I think it's very critical not to make that NED role tokenistic to our desire to look more diverse.
No, good point. Let me go Susanna and then Steve.
Okay, thank you. So, I mean, one of the really important things that Vanwell talked about was the reminder that we had during COVID of the issue about health inequalities, which is not a new one. It's just that we've now got a bit of a renewed focus on that. And what's really important is that there's a very clear link between the EDI agenda and addressing health inequalities for our population. So clearly the ICB should be leading in that respect and should be exemplary in that. And, you know, examples like Peter's given from our county councils. But we had a Thinking Differently Together event not that long ago where a very diverse, diverse range of partners across all the different partners. So we had partners there from social care providers, voluntary community sector, district to borough councils, NHS providers as well. Everybody, you know, this is a really kind of key issue, and it's one where I think, you know, we need to be setting that kind of collective ambition for the whole system and holding one another, you know, mutually accountable for making progress on that and keeping that up on a regular basis and not letting that agenda drop, because I think the moment that we had where we realised we had dropped the ball on that was quite sobering for a lot of people.
Yeah, thank you, Susanna. Steve and then Andrew.
I want to come in on the kind of tokenistic point that's been made by a number of people. We could chase a whole bunch of numbers and stats and get 13% of our board coming from a black and minority ethnic to represent to be reflective of the population. But if that's all we do, then we won't have done the square root of a lot of little. Because the real thing is that, because we will never, even if we had 13% of our board representing black and minority ethnic groups, they won't represent all black and minority ethnic groups, because the difference with somebody who comes from Kerala and somebody who comes from Uganda is massive. It's as big as any difference you might find in any other population. So the challenge for us, and I don't know quite how you measure it, is that every one of us is much more open to the notion that there are other ways of seeing the world than the one that we're used to by virtue of our lived experience, which will vary around the table. We're all different. But somehow or other, we have to be able to be more able to acknowledge that the world is different for those who come from a different perspective than our own, whatever that is. Now, I haven't a clue how you measure it, but that's the end point for me, not having a certain number of persons who happen to have a particular ethnic stamp on them. And I know this is something Fanny and I've talked about, and it's. I think you agree with that, but you'll tell me.
Fanwell, go on.
Thank you, Chair. And yes, we've discussed that, Steve. I think the thing to note is that why do we do this? Why are we even talking about this? It is about the diversity of perspectives, which is shaped by people's lived experiences that we want on this board. We're talking about addressing inequalities, and there are things that will be informed by people that are coming from different perspectives, different backgrounds that inform that process. Now, that is not to say somebody has to be black, brown, disabled to be able to do that. Some of the work that we're talking about that needs to be done with the board is really around how do we get the people that we have to start doing that reflective process and be able to say, if we thought about this, if we considered that, if we, and being able to factor that into the everyday, processes that we. So, yes, we can go on that journey and get everyone here to do that. But as we go on that journey, it might also be useful to then have, some of those people with that lived experience to be part of that as well.
Okay, so recognising the challenge, and as we've said so many times today, getting it right is a challenge in itself, isn't it? Let me go to Andrew and then Frida.
Could I just come back on this point?
Of course you can.
Sorry,
yeah,
Andrew,
yeah.
Is that all right with you?
Yeah, go for it, Frida.
Or do you want to come back on this
Can I come in?
Yeah, of course.
Yeah, so coming back to both Steve's, actually, I think somebody from Kerala and somebody from Uganda have something really important in common, which is they're both victims of racism. And we've absolutely got to recognise that and respect that. And that's a really important factor for us to draw out. We must never, ever forget that. I think there's a risk that we will forget that if we look at what they've got different rather than what they have in common, because it's what they have in common that's toxic to us. The second point is, Steve, my view of this is if you concentrate on diversity of thinking rather than protected characteristics, you concentrate on things that you know about. And we don't need to know what we all know about. We need to know things that we don't know. And the only way you can draw out things we don't know is by having diversity of protected characteristics, because only those of us with protected characteristics know what our lived experience is. And I will know things with my sexuality that you will not know as a white heterosexual man. So we have protected characteristics, and we should focus on them for a really good reason, because it teaches us things we don't know ourselves.
So I'm not arguing against recognising the protected characteristics and including them. I'm saying it's more than that.
So why not start there?
Oh, did you say we should start?
We did.
No, I didn't. So we should just take the numbers. There's
Well,
more to it. There's an end beyond.
So let's take that as the clarification of Steve's position. Let me go to Frida.
I actually think Andrew said what I wanted to say, actually, and thank you for that, Andrew. I appreciate what you've just said, and I hope people really listen to what Andrew said about lived experiences and how important they are. And, you know, just because you're from one end of the world to another, you know, you do actually have a shared experience from racism, and it's deeply important to recognise that. And also, I'd like to say, is how do we look to our population? And we don't look very good at the moment.
Hence why we're having the discussion, of course. Tanya.
I was just going to support that. I think this conversation shows the sensitivity around the topic, and that white privilege actually exists in all of our thinking and all of our work, and we have to move ourselves beyond that, and we need that done really well with facilitation. And it's not a one-off conversation. This is an ongoing cultural change for the organisation, in my view. And I think it is about representation, and if people can't feel that they have a place at this table because they can't see themselves, that's a problem. And actually that's a problem for our communities, and it should be a problem for us as leaders. So I don't sit here with all the answers. We've had some great conversations as we've been trying to pull the paper together, and I see this very much as a starter for 10, and the conversation has to keep evolving, but it will never stop.
One more point. Thank you, Tanya. Frida?
Very quickly, I think this just draws the urgency for us to have a board development on EDI, please.
Yeah. So let's see if we can move forward then. So we'll take that as another board development. We've got a lot of board development coming, haven't we? But new board. So we'll take that as an action. And then would I be right in saying, Amanda, that in actual fact, if the board today is agreeable of the direction of travel that is encapsulated within the paper, that we will then receive a more detailed report at November board with an action plan, which the theory is we'll be putting in place for delivery from April. Is that where we're going?
Indeed, spot on. Thank you.
Is everybody content with that? Agreed? Fantastic. Thank you very much. In which case, I'm going to move us rapidly on, just looking at the clock, to item 18, the Chair and CEO action paper. Amanda, it's still with you.
Thank you very much, Chair. So very briefly, this action has been taken, and we as a board are required to endorse the action taken by the Chair and Chief Executive in terms of allowing, for want of a better phrase, the Director of Contracts to be signing contracts going forward.
Would anybody not like to endorse that? Should we take it as endorsed? Thank you very much. 19, appointment to the auditor panel. Chris.
Yeah, the audit panel, in terms of reference, were approved earlier on in the agenda. This is to appoint the members to that panel. The panel's job is to kind of oversee and appoint our external and internal auditors. The proposed panel within the document, it would be Steve Clark as chair of the audit committee, Tanya, and the ICB director of finance. So the terms of reference require that the majority of kind of lay members and have no fewer than 3 members.
which is delivered in the paper as recommended. Any issues, any questions? Is everybody content to approve? Approved. Lovely. In which case, item 20, the committee minutes and highlight reports. Amanda, are we able to take these en bloc, do you think, for questions?
Yeah, I think we could, Chair, actually. These are from those committees that have since met since the last board meeting. And yeah, I think we just take en bloc and take any questions as appropriate.
So, thank you, Amanda. Any questions on any of those papers?
Just
go on, Chris. Steve.
Clarification.
Yeah,
The
yeah.
committee met yesterday and signed this lot off.
Ah, right.
Sorry, the meeting of the 18th. So those have
been signed off.
Okay. Obviously, there's not yesterday.
Of course. But we'll note that in these minutes, we'll note that they were confirmed yesterday. Thank you for that, Steve. Any other questions or points? Noted, received and noted. Thank you very much. Item 21, any other business? None has been notified. Does anybody, I'm looking around the table, wave at me if you have any other business? No other business. Date and time of the next meeting, 22nd of November, 9 o'clock. Look forward to that. And that then takes us on to item 23, which is questions from the public. So I'm looking at Simon, you're shaking your head. Nothing's come in, Simon. Okay, and Michael, you've got one question you'd like to raise. Do you want? Yes, I would. Do you want to go to a microphone, Michael?
Well, I've got quite a loud.
Yeah, go on. I can hear you. Yeah, go on.
I'm a technophobe, so I've not been able to meet or follow any of your meetings or the preceding meetings by the CCG, and this is the first opportunity I've had to come to a public gathering of your good selves. It looks as if you've got a massive task ahead of you, and I sympathise with every one of you. Some of the faces are familiar. My face is familiar to them. What I really came to discuss today really was, I live in a seaside town which just before COVID had one of the 4 surgeries that it had closed down because of the inability to find staff. Since that time, the number of dwellings that are being built in our town is somewhere in excess of 4,000. That's of a population currently that's housed in just over 11,000 dwellings. I'm a member of my PPG of my surgery, and we recently had a meeting at which we asked what progress was being made on being able to meet the demand of an additional 10,000 people. And our partner doctors said that they had plans and they'd gone forward, and they were told that the NHS was not prepared to guarantee the loan to enable the building and the expansion, so that the service that I'm getting and future prospective patients would get would be able to be met and funded. Can you explain why the SIL that is taken from developers, etc., isn't able to be utilised straightforwardly to meet the demands that they will be putting on the existing primary care services?
Okay.
Just a simple question.
Yes, it might not be a simple answer, and it may be something that we have to answer in slower time. But
I'll follow Frida.
You over to Frida first, then.
Yeah, I had a similar experience in my practice where we wanted to develop, because we've got also our village is growing and growing and growing, and we put forward, we own out, we're a practice owning, we own, the partners own the building, and we had a developer, so very similar to what you're describing in Felixstowe, and what happened was we have a market surveyor, basically a valuer who NHS annoyance or whatever, and they come across and they tell us exactly what our practice is worth to the NHS in rentable value. So basically the NHS rent our property that we own for a certain amount of money. Now, when the developer comes along and he builds a £2 million building or extends for £1 million or whatever it is, he will have different expectations to what the valuer will have. So the problem is that whilst our value for our properties as it stands at the moment is acceptable to the NHS and they pay us that rent, cost rent, when a new building is made, or we're notional rent, when a new building is made and it's cost rent, then the developer will ask perhaps a lot more. So we would perhaps earn, well not earn, we rent it for 50,000, say, approximate, but the developer may build such a building that he wants a return of about 200,000. And that kind of conflict is what is prohibitive in terms of primary care development, estate development. Because whilst we go to developers, and we then become tenants essentially and no longer owners on a lease, the point is that the difference between what we at the moment with not fit for purpose premises are being paid is far less than what these new beautiful developments will cost if the NHS agree to do that. And unfortunately the money isn't in the system to pay the developers what they want and probably need to cost their own outgoings, and yet we're much cheaper basically. And that's the conflict a lot of primary care, particularly partnership owning properties, are having in terms of development. Does that all make sense to you?
Yes, very helpful.
Yeah, I hear your answer, but in our situation, the building is brand new. They're looking to extend the existing building. No single development is looking to provide a surgery at all, but there is still money, and that is money that the local authority has and charges the developer, that should be available to provide primary care health, or at least it should make a contribution, and that apparently isn't happening. So you are responsible as a board for care in the community, and it strikes me that if the GPs aren't being supported to have adequate surgery space for a known 10,000 extra population, that really is a major failing of the whole system.
So let me just hold you there, Michael and Frida. Good points that you're raising, but the but I've got here is how do we deal with it now? And also the questions should really be exactly on agenda items. So the way we, I think, should be dealing with this is perhaps to take Michael's points and actually answer in a slower speed. I don't mean slow, but in a written way, and we can add a written answer to Michael's question to the minutes, which will go on the website. But let me go to Ed to see if you can make sense of that as an approach, Ed.
I'll bring in Peter in a second, but we now have 3 alliance directors within our board here, and Maddie Baker-Woods is the one that covers Felixstowe, which you're referring to, if I can work it out. And those directors are now roles working in collaboration with the local authorities as well as the NHS. And part of the work that Peter, I'm sure, will touch upon now is we're thinking about primary care provision, looking at the growth of population, but also the growth of roles in primary care. And we haven't necessarily got the accommodation to accommodate everyone. So we've got a real issue. So I think we absolutely recognise it. I'll ask Maddie to follow up with you specifically on the Grove. And Peter, you may want to add your perspective.
Go on, Peter.
Thanks. Yeah, I'd probably said something similar. What would I wish Maddie would say if I wasn't here, so to speak, on our behalf? I think it's 2 follow-ups. There is a specific response to the Felixstowe circumstances, but I think this has a much wider, SNE-wide national issue. That if we have this massive ambition for left shift and we've got growing populations that are not evenly distributed, so this falls differentially, and that lease story is one that is told many times around SNE. So I think there is a strategic theme for us to return to as a board, because it's a major strategic issue we're going to need to find a way through. So I think there's a suggestion, as you've said there, two courses, 2 things to follow up to bring back as a future item.
Great. So we'll deal with that as a written response. Thank you very, very much, Michael. Thank you. Okay, everybody. So 10 to 5, we've dealt with the entire agenda. I think we can close the meeting as of now, this meeting. We do have a very, I hope, a very, very short part 2 meeting to follow. But shall we have a 2-minute break if we can, and then we'll reconvene in private session. Okay, thanks very much, everybody. Thank you.